எல்லோருக்கும் வணக்கம்.
Good evening, sir.
Good evening.
Good evening, sir.
Good evening, sir.
Good evening.
Good evening, sir.
Good evening.
Good evening, Debasis, Thirumurugan, Akila, PR Sister, Lakshmi, Sendil, Sendil Kumaran, Sharda, எல்லாருக்கும். Thirumurugan இது ஒரு மல்டி ஸ்டாரர் மூவி.
சொல்லுங்க சார்.
எத்தனை ஸ்டார் பாத்தீங்களா? 9 11 ஸ்டார் இருக்கு.
இது வந்து மெகா பட்ஜெட் மூவி. பட்ஜெட் எல்லாம் நான் ஒரு லீஃப்லெட்டுக்குள்ள போறதுக்குள்ள நான் ரொம்ப யோசிக்க வேண்டியதா இருக்கு.
நீங்க படம் எப்படி போறீங்கன்னு எனக்கு ஒரு ஆச்சரியத்தோட பார்த்தேன். எப்படி படத்தை போட போறீங்க?
எப்படியா போட்டுருவோம் தான் சார், நம்பிக்கை தான் சார்.
சார் பியர் சார் நீங்க தான் பிரசன்ட் பண்ணணும். ஃபர்ஸ்ட் ப்ரொஜெக்ட் பண்ணனும். நான் அதல இருந்து பேசுறேன்.
I will give the presentation. நீங்க அப்படியே பேசுங்க.
எல்லா ஃபேக்கல்டிக்கு அந்த ரெண்டு லாஸ்ட்ல இது பண்ணுவோம் இல்லீங்களா? ஷார்ட் லிஸ்ட் பண்ணுவல அதான் வரும். சாரதா லட்சுமி எல்லாருக்கும்.
சார் சொல்லுங்க சார்.
இல்ல எல்லாருக்கும் அந்த லாஸ்ட் ஷார்ட் லிஸ்ட் பண்ண முதல்ல நம்ம நிறைய பிளான் போட்டோம். அதெல்லாம் விட்டுட்டு ரெண்டு குழந்தை போதுன்னு முடிவு பண்ணிட்டோம். அதனால
சரிங்க சார். அந்த கடைசி ஷார்ட் லிஸ்ட் பண்ண விஷயம் தான.
அந்த லிஸ்ட் இருக்கு.
சரிங்க சார், சரிங்க சார்.
ஓகே சார், ஓகே சார்.
புனிதா வந்துட்டீங்களா?
சார் அகிலா சார்.
இல்ல புனிதா இல்ல. எனக்கு தெரியுது. அகிலா தெரியாம இருக்குமா?
ஓகே.
செந்தில் வணக்கம் செந்தில்.
தெரியுறாங்க ஆனா தெரியல.
ஆமா.
சார் குட் ஈவினிங் சார்.
செந்தில்.
Good evening.
உங்க சீன்ஸ் தான் டாப் கிளாஸா இருக்க போகுது. நீங்களும் நம்ம பிள்ளை சார் பேசுறதா எல்லாம் தெரியாத பாய்சன்ஸ் எல்லாம். பாராகோட்டிக் ஸ்பெல்லிங் கண்டுபிடிக்க ரொம்ப கஷ்டப்பட்டாங்க. ஒரு 4-5 ஸ்பெல்லிங்லாம் போட்டு கடைசியா கிடைச்சு. அதே போல மெர்க்குரி, ஆர்சனிக்லாம் தெரியாத விஷயங்கள். சார் செந்தில் அங்க இதுலதான் எமர்ஜென்சி பண்ணார் ராமச்சந்திரால. யூஸ் டு கம்பேர் பால்ஸ். முன்னாடி எல்லாம் ரெகுலர் பால்ஸ் வருவாரு. அவரும் அவருடைய சந்திரசேகர்
எக்ஸாமினர் சார்.
இங்க ராமச்சந்திரால பண்ணாரா?
எமர்ஜென்சி.
ஓகே ஓகே.
சார் நீங்க எக்ஸாமினர் சார்.
எக்ஸாமினரா நீங்க பாத்துறீங்களா?
அப்படியே.
ராமச்சந்திரன் சார் இருந்தார் இல்லீங்களா? அப்படிதான்
ஆமா, வீட்டு இப்போ வரதான் அவருக்கு.
டிவிஆர் தான் பண்ணீங்க இல்லையா?
ஆமா, டிவிஆர் தான் இப்போ.
ராஜ்குமார்.
குட் ஈவினிங் சார்.
குட் ஈவினிங் ராஜ்குமார்.
கிளியரா இருக்கு சார் ஆடியோ?
நல்லா இருக்கு. கிளியரா.
நல்லா கிளியரா.
உங்களுடைய வாய்ஸ் ரொம்ப நல்லா இருக்கு. சிவாஜி வாய்ஸ் மாதிரி இருக்கு அப்படியே. சத்தமே காணோம் ராஜ்குமார்.
என்ன சொல்றதுன்னு தெரியல சார். எப்படியோ லாஸ்ட் மினிட்ல ஸ்லைட் அமுச்சிட்டு
எல்லாம் சரக்கு இருக்கு, உடனே போட வேண்டியது.
அவ்வளவுதான், எடுத்து அளந்து போட்டுற வேண்டியதுதான்.
TVR also is joining. Yeah.
Good evening, TVR sir.
Good evening, Dr. TVR.
Good evening, sir.
Good evening, sir.
Good evening. Good evening. Welcome.
Welcome, sir. Sini இன்னும் வரல இல்ல? Sini தான்.
Yeah.
Sini தான் first speaker. எப்படி போறது? கொஞ்சம் அவருக்கு சீனிவாசனுக்கு கொஞ்சம் திருப்பி அனுப்புறீங்களா? திருமுருகன்
சார் சொல்லுங்க சார்.
சீனிவாசனுக்கு லாகின் பண்ண முடியலன்னாரு. கட் பண்ணிட்டு வாங்க மறுபடியும்.
சார் நம்ம இந்த சார் அது நான் மொபைல்ல இருக்கேன், கொஞ்சம் அனுப்புறது கொஞ்சம் இஷ்யூ இருக்கும் சார். நான் லாகின் பண்ணி அவர் பேனலிஸ்ட் லிங்கா கூட வரணும் சார். நம்ம ப்ரோமோட் பண்ணிடலாம் சார்.
சீனிவாசன் ஜிப்பர் நம்ம இவரு.
ஓ அவரு சார் சார்
இல்ல சார் இல்ல நம்ம இப்பன்ல டிஎம் பண்ணி
ICH யூனிவர்ஸ்.
ஓ சீனிவாஸ் கும்மி அவர்தானே, அவருக்கு ஒழுங்கா போச்சு. ரைட்,
ICUல இருக்காரு.
தெரியும் சார், தெரியும். ஒரே செகண்ட் சார் இருங்க, ஜஸ்ட் அவரு பார்ட் இந்த லிங்க்ல ஜாயின் பண்ணா கூட நம்ம இது பண்ணிக்கலாம் சார், போட்டுடலாம். அது ஒரே ஒரு நிமிஷம்.
Sir, good evening.
வணக்கம்.
Good evening.
Sir, good evening.
Good evening, Dr. Gopal.
Good evening, sir. Ismail, good evening.
Good evening, Gopal. Good evening, sir.
Sir, Ismail sir.
Sir, good evening.
Good evening, sir. PRC, sir. Good evening.
Good evening, sir. Good evening. Welcome.
ரமேஷ் பாபு சார் வணக்கம்.
ஏன் மின்டரா?
Good evening, sir.
Good evening பாபு.
Good evening, sir.
Ramesh, good evening, Ramesh.
Good evening, Ismail, sir. Good evening.
Vijayaravan sir, good evening. Good morning. Good morning,
good evening,
Vijayaravan.
sir.
Good morning, Vijayaravan.
Good morning. Good morning. Good day.
Sir,
Good morning.
sir.
Good evening. Good evening, sir. Good evening.
Good evening, come good morning, sir.
Good morning.
ஒரே ரொம்ப குழம்பு போயிருக்காரு இப்போ நீ.
Sir. Sir, good morning.
அண்ணா விஜயராவன் நல்ல பிரைட் ஆயிட்டீங்க விஜயராவன். சுத்தமான காத்து தண்ணி போயிட்டு
உட்கார்ந்துட்டு இருக்கு.
பளபளன்னு இருக்கார் சார். கலர்
ஆமா.
வெள்ளைக்கார மாதிரி
இங்க மார்னிங் சார். மார்னிங் மார்னிங் சார். ரமேஷ் சார்.
Good morning, sir. Good morning, sir. Good morning, sir.
ஓகே நம்ம இவருக்கான
Dr. Gopal sir, good morning.
Morning.
Morning sir.
ராஜேந்திரன் வரல இன்னும்.
Srinivasan.
Sir, good evening, sir. நல்லா இருக்கு sir.
Good evening. நல்லா இருக்கீங்களா? ஓகே.
லேட்டஸ்டா வராரு.
அதாவது தட்டி உடைச்சு வந்துட்டீங்களா உள்ள சீனிவாசன் எப்படியோ?
Sir,
ராஜேந்திரன் வரல இன்னும்.
வந்துருவார்னு நினைக்கிறேன் சார். ஞாயிற்றுக்கிழமை தோட்டத்துக்கு போயிருப்பாரு.
குதிரையில வருவார்.
தோட்டம் பாதரம் பார்க்க போவார்.
அமல்ராஜ் வணக்கம். அமல்ராஜ். எம்எஸ்வி.
Dr. Amalraj.
Good evening, sir.
Good evening.
Good evening, sir. Good evening, sir. நல்லா இருக்கீங்களா, sir?
Good evening everyone.
நல்லா இருக்கு.
Good evening, sir.
நல்லா இருக்கு.
Sir. அண்ணாமலை, sir.
தங்கவேலி டாக்டர் பிள்ளை ஜாயின் பண்ணிட்டாரா?
இப்பதான் join
Good
பண்ணாரு.
evening.
Good evening, all.
அமல்ராஜ், good evening.
Good evening, sir. Good evening, sir.
எம்எஸ்வி.
Good
Good
evening.
evening, MSc.
பிள்ளை சார். குட் ஈவினிங் சார்.
Ismail,
Welcome.
sir.
Good
Good evening,
evening,
Gopal,
Pillai,
sir.
sir.
Good evening, sir.
Good evening.
Good evening,
Sir,
sir.
Yeah, he has joined. The Pillai also has joined. Welcome, sir.
வெல்கம் சார். குட் ஈவினிங் சார்.
Good evening, sir.
ஜனனி குட் ஈவினிங். மகாதேவன் சார்.
Good evening, sir.
Good evening, Tangavel. Good evening, Ramchandra.
நல்லா
Good
இருக்கு.
evening. Good
Good
evening,
evening,
Dharma.
sir.
Good evening, sir.
Good evening, all. Good evening. Good evening.
Rajendran has joined,
Rajendran.
sir.
டைரக்டர் ஆஃப் த மூவி ராஜேந்திரன் வாங்க. Pillai sir, this is a monthly program, sir. Every month, second Sunday, different programs are conducted focusing on the practitioners.
Sir. I'm privileged to be here, sir.
We are happy to be here sir, because this is one of the major department having toxicology and analytical laboratory.
Sir.
We are very happy to have you here. And
audio கேக்கல.
Thank you, sir.
Audio.
எங்களுக்கெல்லாம் கேக்குது நல்லா.
Rajendra, sir.
Good evening.
ஆரம்பிச்சலாமா?
Good evening, sir. Good evening, sir. Sorry, sir.
Good evening, Dr. Rajendran.
I was
Good
held up
good
in
evening.
traffic, sir. Sorry.
7:30 ஆரம்பிச்சலாமா கரெக்ட்டா?
கரெக்டா ஆரம்பிச்சிடலாம் சார். டாக்டர்
Sir, good evening.
ரமேஷ் பாப் ஜாயின் பண்ணிட்டார் இல்லைங்களா?
பண்ணிட்டார்.
ராஜ், good evening.
சார் குட் ஈவினிங் சார். குட் ஈவினிங் சார்.
Raj, we can start.
Yeah, we'll start. Good evening to everybody. On behalf of IAPTNSC, I welcome one and all. First, we'll start with the pediatrician prayer by Dr. Gopal Subramaniam, our treasurer.
Good evening, seniors and my dear friends. We'll start today's program with the pediatrician's prayer. குழந்தை பிரச்சனை நிறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும் உயரின் துன்பத்துக்கும் தரும் நமக்கு வழங்கப்பட்டது இப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வுமாக எல்லா குழந்தைகளுக்கும் அவர்களின் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம் கற்றல் அன்பு அமைதியாக நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாத போதுமான எங்களுக்கு வழங்கும் உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். நன்றி.
Thank you, Dr. Gopal Subramaniam. Now I welcome our dynamic president, Dr. Ramesh Babu, to deliver presidential address.
Thank you, Dr. Rajendran. I won't take much of time because today's topic on this poisoning and toxicology is there's got a lot of speakers and know the
Dr. Punitha, please mute. Dr. Punitha, please mute.
We all know the hard work done by Professor Thangvel sir over the past 10 days for coordinate with all the speakers, resource persons and panelists and all. At this juncture, I take pleasure in welcoming all of you, the respected President 2021, Dr. Ismail sir, President-elect Dr. Suresh Balan, our Dynamic Secretary Dr. Rajendran, and Treasurer Dr. Gopal, and all the Central IAP EB members from our state, and the State IAP EB members, and the District Office Bearers, as well as the delegates who are joined in large numbers in the Zoom platform, as well as those who are viewing in IAP YouTube channel. My special thanks to the chairperson and the convener, Dr. Thangvel sir and Professor PRC sir, and the resource persons, and the 8 panelists who are going to present us with their knowledge and about the various toxins, which will be very useful for the practicing pediatricians. And apart from pediatrics, we learn many more things from our convener, Dr. Thangvel sir. Sir, thank you very much for coordinating this monthly CME on every second Sunday of every month. We are indebted to you, sir. Thank you very much. With this short note, I hand over the proceedings to the Secretary, Dr. Rajendran, to proceed further. Thank you.
Thank you, Dr. Ramesh Babu, our President. Now I request our President 2021, Dr. M. Ismail, to felicitate. So unmute.
Thank you, Raj. President Ramesh, Rajendran Secretary, and Gopal Subramaniam, Treasurer, the convener of the course, Dr. Thangvel sir, Dr. PRC sir, the resource persons and the faculty. I warmly welcome you all and a good evening to you everybody. I think I'm very happy that IAP is still continuing the program for the practicing pediatricians, and especially today's topic is still more relevant, the practical aspects of poisoning in children. As a practitioner, I myself feel sometimes very difficult to make a decision when a child is brought with acute poisoning or taking some tablets or say taking some liquids or something like that. But I think this is a relevant topic for the practicing pediatricians. I wish you all a happy learning, and I thank IAP for taking up this project in a big way. Thank you.
Thank you, sir. And respected our President, Dr. Ramesh Babu, and President-elect Dr. Suresh Balan, and President 2021, Dr. Ismail, and Treasurer Dr. Gopal Subramaniam, our Vice President Annamalai Vijayaraghvan sir, Joint Secretary Dr. J. Balasubramaniam, and AAA Dr. Thirumurugan Sarane, and all other central as well as state EB members. On behalf of IAPTNSC, I welcome one and all. And first of all, I would like to thank and welcome our convener of the program, Dr. S. Thangvel sir. And he usually is having a lot of work in the IJPPA also, and arranging CME also. And in spite of his busy schedule, he has organized this poisoning. Really, on behalf of IAPTNSC, thankful to Dr. Thangvel sir. And I welcome Dr. Thangvel sir, program convener. And our welcome today's moderator, Dr. Ramachandran sir, is Dean and HOD, Department of Pediatrics, SRMC. and I welcome resource persons Dr. Srinivasa Subramani and Dr. T.V. Ramakrishnan, Dr. V.V. Pillai, and panel discussion panelist Dr. Raja Kumar, Dr. M.P. Jayakrishnan, and Debasis Das Adigari, Dr. Sarada Satish, and Dr. M. Lashmi, Dr. V. Agla Devi, Dr. S. Sendil Kumaran, Dr. Punita, and on behalf of IAPTNSC, I welcome all the delegates and as well as faculties and teachers, and really happy that we are having a monthly practice in pediatrics in CME. And thank you, one and all. Now I hand over to Dr. S. Thangavelu, sir. Sir, please take over, sir.
Good evening, welcome everyone. Respected teachers, IAP, office bearers, and all the faculty who has come with knowledge to share with every one of us. I invite you all for this interesting program. I request Professor P. Ramachandran to present the slides. I request all the faculty to please open the video so that we'll have the introductory program. At the time, I can see your images. This is a TNSC CME for practitioners and practical aspects of poisoning. First lecture is by Dr. Srinivasan, Initial Recognition and Resistation. Then followed by Professor T.V. Ramakrishnan on Decontamination. Professor V.V. Pillai on Role of Poison Information Center and Toxicology Lab in Childhood Poisoning. This is followed by a panel discussion with the moderator, Professor P. Ramachandran and Dr. S. Thangavelu, and panelists Dr. Akila Devi, Dr. Debasis, Dr. Jayakrishnan, Dr. Lakshmi, Professor V.V. Pillai, Dr. Punita, Professor Rajkumar, Dr. S. Sindhil Kumaran, and Dr. Sharada, followed by an open house discussion. So we're starting with 7:30. I expect that the program might go up to 10 o'clock. So can you move the next slide, sir? Yes, sir. Can you move the next slide?
Yeah, I'm trying. I don't know.
We can double click and. I'm very happy to introduce the very strong faculty. This first time we have brought faculty from more experienced institutions. Dr. Srinivasan is an assistant professor of pediatric intensive care unit at Institute of Child Health, Chennai, attached to Madras Medical College. He got a lot of interest in toxicology and also published papers. He's the only DM pediatric critical care person in Tamil Nadu government public sector hospitals. Professor T.V. Ramakrishnan, professor and head of emergency medicine at Sri Ramachandran Medical College Research Institute, Chennai. And I'm very happy to is our very long time friend, more than 3-4 decades of friend. He used to be with as a PALS faculty along with us. I think probably is the person who started the emergency department in SRMC long back. And then to mention about Professor V.V. Pillai, he's one of the unique person. He has published a book on toxicology. It's a very wonderful book. It's a very good reference manual. I have a book. Whenever I have any problem, I use refer. Extensively covered all aspects of Indian toxins. He's the chief of Poison Control Center and head of analytic toxicology and professor of forensic medicine and toxicology in Amrita Institute of Medical Sciences, Cochin. We are very happy to have you as a faculty, sir. My dear friend, Professor P. Ramachandran, Associate Dean of PG Students, Sri Ramachandran Medical College and Research Institute. He's a former editor of IJPP and former director in charge of Institute of Child Health, Chennai. He's going to be the chairperson for this program. And also he is going to moderate the first round of panel discussion. We have 2 rounds of panel discussion. The next slide, sir. Faculties I just arranged in alphabetical order. Dr. Akila Devi is a junior consultant in Rio Hospital for Women and Children from Madurai. He is a pediatric emergency person also. And Professor Debasis Das Adhikari, professor in charge, Department of Emergency, professor and in charge of Department of Emergency Medicine, Krishna Medical College and Hospital, Vellore. He has published many papers in poisoning. My dear friend, Professor Jayakrishnan, additional professor of pediatrics in charge of PICU, Government Medical College, Kozhikode. He has also published papers, particularly in iron poisoning. He has published many papers. And Dr. M. Lakshmi, senior consultant in pediatric emergency medicine, Kanchi Kamakodi Children's Hospital, Chennai. Dr. Punita, senior assistant professor of Government Medical College, Dharmaburi. Professor P.S. Rajkumar, professor of pediatrics and in charge of PICU, Sri Ramachandran Medical College and Research Institute. Dr. Sendhil Kumaran, medical director at Manian Medical Center, Erode, and is also faculty of emergency medicine toxicology. And Dr. Sarda Satish is the head of pediatric emergency medicine and teaching faculty of DNB from Mehta Multi-Speciality Hospital, Chennai. With this, we'll move on. I'll request Professor P. Ramchandran, the chairperson, to take over and conduct the first round. Take over, sir. And I'll invite Dr. Srinivasan to have his first lecture.
I will stop sharing.
Yes,
Just
sir.
give me a...
3 lectures followed by 2 rounds of panel discussion.
Yeah.
Dr. Srinivasan first and Professor T.V. Ramakrishnan followed by Professor V.V. Pillai. These 3 lectures followed by first round of panel discussion and second round of panel discussion. Sini. Stop sharing. Over to Dr. Srinivasan.
Srinivasan, you can start.
Yeah, visible. Yeah, you can proceed, please.
Good evening, Thangvelu sir, PRC sir, all my seniors and friends. Thanks for the nice introduction, sir. The next few minutes, I'll be talking about the recognition and resistation of poisoning in children. So, any child with suspected poisoning, there should be any positive history. The onset of symptoms are usually symptoms. Of course, there are some exceptions. This constellation of symptoms may not be fitting into usual pathological diagnosis, or it may be fitting to some clinical toxindromes, which will be discussed later. There are other clinical clues, and if required, some bedside tests like capillary blood glucose, arterial blood gas, ECG, and X-ray may be required. So, this table column is taken from Nelson. I purposely put it not to go in details into it. There are few tables in the Nelson. Whenever I get suspected poisoning, I go open the Nelson book and put the clinical history and clinical findings into the tabular column, and usually we'll get the diagnosis. In the current era, with the availability of soft copy of Nelson, the laptop, or even mobile phones, it is easy to identify many rare poisoning. So, what to look for a child with suspected poisoning? As usual, when you approach any sick child, the ABCDE approach is taken in a child with suspected poisoning. Airway, whether it is clear, maintainable or not maintainable, breathing, whether the breathing is depressed, tachypnea, acidotic breathing, any added sound because of aspiration, pneumonia, and saturation is very important. And circulation, look for any tachycardia, bradycardia, hypertension. There are a few poisoning which cause tachycardia, a few poisoning which cause bradycardia, hypertension, any flushing, cyanosis, and ECG. With the ability of multi-channel monitors, even in all government hospitals, we have multi-channel monitors. When we connect the ECG leads, we could see the ECG changes like widened QRS, prolonged QT intervals, bradycardia, conduction blocks, etc. In disability, look for modified Glasgow-Coma scale, which was introduced long back in the year 1967, which is still useful, one of the most important deciding factor whether the child needs intubation or any other acute therapy. Look for pupils, whether it is constricted or dilated, tone, power, and capillary blood glucose. 20 years back, we found difficulty in looking for capillary blood glucose in all sick children, but now it's available even in small taluk hospital, where whether the child present with coma is having diabetic ketoacidosis or hypoglycemia, etc. An exposure, look for color, spills, any peculiar odor, hypothermia, secretions, salivation, whether the mucosa is dry, any oral lesions like corrosive poisonings like alkali or acid, lacrimation, etc. So this is the poisoning statistics in ICH in the last 10 years. The most common poisoning is kerosene, which is about 1,200, and this is one of the most common cause of mortality in poisoning. See, the total number of poisoning is around 2,400 in 10 years, and among this, though the mortality is less, but it is significant and it is preventable. Kerosene is the most common cause of poisoning, and paracetamol is one other poisoning causing important cause of mortality. The other poisonings are detergents, mosquito repellents, turpentine, rat killer, pesticide, iron, paraquat, and tablet poisoning has significant number 200, of which paracetamol is the most common cause. And what are the causes for hypoglycemia and poisoning? Sulfonylureas like glibenclamide, glimepiride, meglitinides, insulin, beta blockers which cause hypoglycemia, ethanol, quinine, and akifluor. Some poisoning will cause hyperglycemia, for example, early salicylate poisoning, calcium channel blockers, caffeine, etc. So, if possible, if the child is presenting with acidotic breathing, do a blood test. The common causes of high iron gap metabolic acidosis are remembered by the mnemonic mud piles, which include methanol, metformin poisoning, uremia, diabetic ketoacidosis, propylene glycol, paracetamol, INH, iron, inborn error of metabolism, lactic acidosis, ethylene glycol, and salicylate. Remember, out of these causes of iron gap metabolic acidosis, only 3 are non-poisonous like uremia, DKA, and IM. Others are toxin-induced. So, if required, some poisons are radioactive. For example, you remember the mnemonic CHIP, which include chloral hydrate, calcium salt, heavy metals, iron, phenothiazines, pleda, enteric coated pills, dental amalgam. For example, last month we had a child with suspected iron poisoning. So the mother was pregnant and was taking iron tablets. The mother does not know whether the child had iron tablets consumed or not. We had a doubt. So we took an X-ray. You could see the iron tablets inside the abdomen. So later we did blood gas. It was showing metabolic acidosis and the iron levels were 600. We treated this child. So if we have doubt of this poisoning, better take an X-ray. These are radioactive. And ECG. So look for any prolongation of PR interval in digoxin and lithium and QRS prolongation in tricyclic antidepressant. This is the most important cause for QRS prolongation. Chloroquine, quinine, carbamazepine, and lamotrigine. And you can have QT prolongation in antipsychotics, erythromycin, clarithromycin, and azoles like fluconazole, ketoconazole. So with this introduction, I'll be talking about a few scenarios where how the recognition of poison was arrived at, and with the available time, I will restrict it to 6 or 7. Coming to scenario 1, a 6-year-old boy was playing with his friends and he came to home lethargic, there was salivation and he started sleeping. And he was sleeping in the prone position. Father noticed that he was having profuse sweating, so he took the patient to me when I was working in Vellore Headquarters Hospital. He was breathless, there was bradycardia, heart rate was 50 per minute, but there was no signs of hemodynamic compromise. He had bilateral crackles on auscultation and pupils were pinpoint. I suspect initially organophosphorus poisoning and I went to near the mouth. There is no smell of organophosphorus in the mouth. The question is it OPC poisoning? So we treated him as OPC poisoning. Later on detailed probing, child was playing with a bare body with his friends in a cornfield with recently sprayed OPC poisoning. So the poisoning toxidrome is remembered by the mnemonic dumbbells, which include diaphoresis, urination, meiosis, bronchoria, emesis, lacrimation, and salivation. The antidote in this child is atropine. This child, though it is clinically fitting into OPC toxidrome, there was no spell of OPC, but here the route of exposure was through skin. So other causes of meiosis are organophosphorus, carbamates, opiate, diazepam, barbiturate, and phenothiazines. Coming to scenario 2, the year 2011, where I was in duty in a government hospital, a 7-year-old male child was brought with history of lethargy, irritability, and fever for a few hours, and photophobia. So there was no seizures, there was no neck pain. So initially I suspected meningitis, but there was no signs of meningeal irritation. Airway was maintainable, tachypnea, there was tachycardia, hypertension, BP was stage 2 hypertension. Pupils were dilated 6 millimeter, not reacting to light. Initially, I thought of meningitis. I gave first dose of ceftriaxone also. There was no any specific smell or any dry oral mucosa. So I was treating as meningitis. Within a few years, the senior colleague, that is the senior colleague of the child was studying in 2nd standard. The another child who was studying 4th standard came that, Anna, the பையன் வந்து ஊமத்தங்காய் சாப்பிட்டான். So the child took Datura, which is also staple. It contains scopolamine, atropine. So it is an anticholinogenic poisoning. The symptoms are mad as Mad Hatter, delirium, blind as a bat, mydriasis, red as a beet, flushing, hot as a hair, fever, dry as a bone. There was no sweating and the skin is warm. So the main difference between sympathomimetic and anticholinergic is sympathomimetic will have sweating, whereas anticholinergic will have warm skin and no sweating. The antidote is physostigmine. In this index case, I didn't give physostigmine because it was mild to moderate toxicity and he recovered with supportive management. The other causes of mydriasis are sympathomimetics, tricyclic antidepressant, cocaine, methanol. So I have a confusion that whether cocaine and methanol will have myiasis or mydriasis. So I purposely put that, I write this like this so that the dilated O shows that they have mydriasis. Cocaine and methanol will have mydriasis. Other causes are glutathione and LSD. Coming to scenario 3, a 1-year-old boy brought by IT professionals to a corporate hospital with history of acute watery diarrhea. The doctor who examined the child found that he had features of some dehydration. There was no fever or altered sensorium. So he was prescribed oral zinc and ORS. So father got the medicine from the pharmacy, he went home, he mixed with water and gave the ORS to the thirsty child. The child was drinking liters of ORS. After 6 to 8 hours, the child was lethargic. So he was brought to ICH ER. So at ER, his GCS was 8/15. So we intubated the child. Admission sodium was 170. We were breaking the heads because what was the diagnosis? There was no history of fever. Why coma in this child? People were normal, reactive to light. On detailed probing, what happened? The doctor who prescribed ORS available in 2 forms, 200 ml sachet and 1 liter sachet. He has prescribed 200 ml sachet to be mixed with 200 ml water, whereas the pharmacist has given 1 liter ORS. So accidentally, the father has mixed 1 liter ORS in 200 ml water. The ORS contains 75 millimoles per liter. So since the concentration is 5 times, the ORS in this child was almost 375 millimoles per liter. This was the reason for hypernatremia in this child. Unfortunately, we lost this child because of ICP. Coming to scenario 4, a 2-year-old girl brought by mother with bluish discoloration of hands for the last 2 years. On examination, airway was clear, breathing, respiratory 30 per minute, work of breathing was normal and there were no added sounds. There was cyanosis, saturation was 78% with oxygen. Circulation, there was mild tachycardia, BP was normal, perfusion was good. Disability, GCS was 14/15, people were equal reactive to light. Exposure, temperature was normal, no abnormal cell, central cyanosis present and no clubbing. So this is a case of acute cyanosis, unlikely to be cardiac or pulmonary cause. So this is the heart rate of the child and saturation with oxygen through NRM 10 liters per minute. So any child with cyanosis with the normal respiratory work of breathing, with normal sensorium, no clubbing, pulmonary and cardiac congenital cyanotic heart disease are ruled out. So this is a case of abnormal hemoglobin, methemoglobin. So on detailed history taking, the father was having aphthous ulcer in the mouth and was prescribed by a GP mucopain, that is benzocaine gel. It was very palatable. The child took off of the tube. This was the tube taken by the child. So he developed methemoglobin. See, this is the co-oximeter. This is non-invasive co-oximeter by Massimo. So the methemoglobin level was 23.9. So we gave the antidote methylene blue. The dose is 1 to 2 mg per kg over a period of 10 minutes. So co-oximeter is of two types. One is invasive, that is blood gas. And another one is non-invasive, that is through massive pulse oximeter. Coming to scenario 5, a 2-year-old boy from Rajasthan settled in Chennai for the last 2 years, presented with history of fever for 1 day and seizures. Child was taken to a nearby private hospital. He was treated as simple febrile seizures and referred to ICH. On examination, airway was stable, breathing was normal, circulation, he had tachycardia, disability, he had irritable disease was around 12 to 13 per 15. On exposure, he had severe pallor. SpO2 was 79% and there was no cyanosis. Despite a saturation of 79%, there was no cyanosis. We did a arterial blood gas, it showed PaO2 was 89. And you suspect normal PaO2 with the SpO2 of 79% methemoglobinemia, but there was no cyanosis. Remember, this child turned to be methemoglobinemia. His methemoglobin levels was more than 20. So we gave methylene blue and recovered. We were suspecting naphthalene blue because naphthalene poisoning, but the father only took the child. After 1 day, the mother came. She revealed that the child was playing with the naphthalene balls. The naphthalene balls will cause methemoglobinemia, and he had no cyanosis because of intravascular hemolysis causing profound anemia. HB was 3.2. So this child having methemoglobinemia without cyanosis because of low hemoglobin. Coming to scenario 6, 3-month-old female child brought by well-educated parents with history of seizure for 15 minutes. He was treated by taking care of ABC, and for disability, we gave 2 doses of lorazepam followed by phosphonate and levetiracetam. After that, seizures controlled. He had an odor of eucalyptus. The grandmother applied eucalyptus over the chest and we decontaminated. Since the child has fever for the last 2 days, initially we thought of complex febrile seizure. We did a lumbar puncture and there was no evidence of infection and EEG was normal. So the final diagnosis was topical eucalyptus oil toxicity. So eucalyptus oil will cause status epilepticus in children who are given orally, but this child, 3-month child with a large body surface area, even topical eucalyptus will cause status epilepticus. So the other causes of poisoning which cause seizures are, remember the mnemonic, come and sit. The drugs are camphor, organophosphor, methylphenidate and other sympathomimetics, eucalyptus, anticholinergic, neem oil, drugs used in antidepressants, salicylate, INH and tricyclic antidepressants. These are the drugs and poisoning which cause seizures in children. Coming to scenario 7, a 3-year-old boy brought with history of fever, altered sensory. His GCS, he was irritable, GCS were 11/15. Heart rate was, there was tachycardia 160 per minute. The peripheries was cold and BP was stage 1 hypertension. Pupils were little dilated, 5 mm each, reactive to light. I don't know the diagnosis. Initially, I thought of meningitis or septic shock. But grandmother came and she was taking that. She told that she was taking amitriptyline. She brought the tablets. She was taking amitriptyline for chronic pain syndrome. This is a case of tricyclic antidepressant poisoning. The ECG showed wide QRS more than 100 millisecond, and R wave. You see the R wave in AVR. Usually AVR will have negative R wave. See your positive R wave. So QRS more than 100 millisecond and a R wave in AVR more than 3 mm are risk factor for toxicity. And the prediction of seizure is QRS more than 100 millisecond, and the child will likely to have arrhythmia if QR is more than 160 millisecond. So treatment is oxygen for hypoxia and shock. So this child is presented with compensated shock. Don't give 10 to 20 ml per kg of fluid bolus, and this child required low volume bolus like 5 ml per kg. The antidote is sodium bicarbonate at a dose of 1 to 2 ml per kg. Coming to scenario 8, a 1-year-old female child from Nellore, Andhra Pradesh, taken to a nearby physician for cough. There was no history of fever. The pediatrician took a chest X-ray and sent the child home with some cough syrup. And the next day, the child developed breathlessness and he was taken to the same hospital. So child was having respiratory rate of 60 with a severe retraction. So child was referred to ICH. In ICH, child present with the respiratory distress and hypoxia. There was no history of fever. Father brought the X-ray taken in Nellore shows features of ARDS. So why ARDS in this child? Is this pneumonia fever? On detailed history, the child was having a coconut bottle with him, probably lipoid pneumonia present with ARDS. Unfortunately, we lost this child because of lipoid pneumonia causing ARDS in this child. Coming to scenario 9, a 9-year-old girl who presented to Jipmer when I was doing
Srinivasan, can you wrap up in another 2 minutes?
Yes, sir.
20 minutes.
Vomiting and abdomen for 3 days. There was no history of fever. Child was stable. He had icterus and hepatomegaly. The liver enzymes were elevated and INR was 6. So child was admitted in ward with a provisional diagnosis of viral hepatitis. The viral markers were negative. On detailed probing, the child revealed that the mother scolded the child for some low marks 3 days back and she consumed rattle poisoning. So it is a yellow phosphorus causing acute liver toxicity and failure. This child developed MODS and we lost the child. So coming to the recognition management, the principles of poison management are decontamination, enhanced elimination, antidote, and supportive care. So any child who needs resistation, the same ABCD approach: airway, head tip, chin lift, intubation if airway is not maintainable, breathing for hypoxia, start oxygen. If apneic or respiratory failure, start bagging. Circulation. Remember, most of the shock in poisoning is low volume bolus. You give 5 ml per kg over 30 minutes, for example, tricyclic antidepressant. If the child had continuous vomiting or loose stool, if the fluid loss is significant, they may have hypovolemic shock. In those situations, we can give 10 ml per kg. Most of the time, inotropes are not required. If the child develops any arrhythmia, for example, TCA toxicity, you treat as per Paul's protocol. Intubation is required if the GCS is less than 9, and exposure, decontaminate, which will be discussed later. Specific antidote during resistation. So these are the common antidotes available for some toxins. Thank you.
Thank you, Dr. Srinivasan, for that wonderful opening. So probably we'll take the questions kindly put up the questions in the chat box. We'll be taking up the questions at the end of the 3 lectures. And if anything left out couldn't be covered, it will be done during the panel discussion also. Now, can I go to the next speaker, Professor T.V. Ramakrishnan from SRMC. He is by training an anesthetist, and he is in charge of the emergency department at Ramchandra Medical College and a wonderful teacher. He will be talking to us about the decontamination procedures, which is a plays an important role in management of poisoning.
Can I share my slides, sir?
Yeah, please do, sir. Sini, kindly stop sharing. Srinivasan, have you stopped?
Sharing.
Are you able to see my slides, sir?
Yeah,
yes,
kindly make it. Yeah, fine. It's fine, sir. Visible and audible.
Yeah, thank you, sir. Thank you very much for this honor. I'm really grateful for this opportunity to share some of my thoughts. I'll be talking to you on decontamination, and I'm going to confine myself only to GI decontamination because that is the one thing that most of the practitioners will be able to do in a private setup or in a clinic before referring patients to another hospital. It's very important for us to know how children are different from adults. Obviously, very young children, infants are non-verbal. They will be unable to provide a history or list the physical complaints. So we are actually dependent on the patient's parents or other attenders to give us a proper history, which may not be perfect during the time of arrival of the child. Children tend to respond to unknown or fearful situations by becoming very anxious and crying. They are inconsolable. So our ability to assess them would also be less unless we are very, very experienced and we have a lot of knowledge on the kind of presentations. Children have a less fluid reserve, which can lead to shock because of loss of fluids also. So we need to keep that in mind. The respiratory rate of children are much faster. And so they can be exposed to a greater amount of, in case there are airborne toxins. They have a permeable skin, like the previous speaker had told, and they are more prone for toxins which have exposed in the air. They tend to become hypothermic faster, so we need to keep that in mind. They have a less mature immune systems, which make them more susceptible to overwhelming infections from biological agents. As discussed earlier, the first priority is always airway breathing and circulation. A quick vital signs of the child, which includes the saturation and hypoglycemia, must always be corrected during the initial encounter with the patient. The first encounter with the patient always is ABC. Make sure the vital signs are all right. Pulse oximeter probe is put in the patient to look at the saturation, and always check the blood sugars. Let's go on to GI decontamination. When does it help? If the child comes to you within 1 to 2 hours of an ingestion, or the child has ingested a poison an amount that is suspected to cause toxicity, and the child does not have clinical factors that make decontamination dangerous. For example, the child may be obtunded, or GCS may be very low. In that case, if you have a child like this, it's safer not to decontaminate the child unless you have facilities to secure the airway by intubating the child and then doing a GI decontamination. The first way of GI contamination is a gastric lavage, where you pass the appropriate size nasogastric tube in case the child is not intubated, or an orogastric tube in case the child is intubated. And what is done is a repetitive installation and aspiration of small aliquots of fluid, maybe 15 to 20 ml of fluid. And then you aspirate it after 5 to 10 minutes each time you actually install it, till the whatever you aspirate becomes clear. But again, there are no published evidence to demonstrate that gastric lavage changes the outcome. So it's a little controversial giving a gastric lavage, but most of us actually practice it. But you need to put the appropriate size of Ryle's tube. And it's a very easy formula where you add 16 to the patient's age and then you divide it by 2. For example, if you have an 80-year-old child, 8 plus 16 would be 24, and you divide it by 2, it is 12. As discussed earlier, what are the contraindications for this? Obviously, I told you earlier, an unprotected airway where you're not very sure. The child can retch or vomit and aspirate also, even when you're trying to put in the Ryle's tube. Caustic ingestion, again, it is a contraindication. Do not try to force in a Ryle's tube if the child has come with an acid or an alkali ingestion, because chances of esophageal or a gastric injury is there. Hydrocarbon ingestion, because of risk of aspiration, especially when your child comes with kerosene or other hydrocarbons. Then do not try to put a Ryle's tube, because the act of putting a Ryle's tube makes the child cough or vomit, and the kerosene would come into the oral cavity and get into the lungs, and you would have problems. So please do not do that. And patients at the risk of any GI hemorrhage or perforation, again, please do not try to put a Ryle's tube. These are some of the complications that can occur, like an aspiration pneumonia or an esophageal or a gastric perforation. The act of putting a Ryle's tube itself can cause a laryngospasm in case it irritates there, so keep that in mind. A child who is dependent on oxygen, you remove the oxygen mask and spend a lot of time trying to put on a Ryle's tube, the child can become hypoxic. And they also say the putting a Ryle's tube and giving a gastric lavage pushes some of the toxins past the pylorus, so that potentially will facilitate the absorption of the poison and decreases the effectiveness of your activated charcoal that you're going to give later. This is as far as gastric lavage is concerned. Now, once you put in a Ryle's tube, then next thing that you can try on patients is an activated charcoal, where actually it absorbs the poison, that way making it less of the poison for systemic absorption, and then it gets eliminated. There are some studies which say that a single dose activated charcoal is benefited when administered within 1 hour of the poison ingestion. while the toxin still remains in the stomach. This is a study that was done in emergency medicine as early as 1990, where they saw that gastric lavage administered with activated charcoal versus activated charcoal alone showed no statistically significant difference in reduction of systemic absorption of acetaminophen between the two groups. And also, in another study, which said that patients treated with gastric lavage had a higher rates of aspiration. So we have to keep that in mind whenever you do a gastric lavage. And if your child is a little uptended, you're not very sure the child is, not very awake, then you need to be extremely careful, and you need to intubate these patients prior to this. Another study was done in the year 1999 in the Journal of Toxicological Clinical Research, where you had 981 patients poisoned with acetaminophen who were treated prior to receiving N-acetylcysteine with activated charcoal or no decontamination. And they found that the patients presenting within 24 hours with ingestion of 10 grams of greater, now that's a toxic dose of N-acetylcysteine, of paracetamol. Administration of activated charcoal prior to N-acetylcysteine resulted in a lower risk of liver injury compared to treatment with N-acetylcysteine alone. So there is definitely a role for activated charcoal in these patients. What is the dose of activated charcoal that we need to give? Up to 1 year of age, you could give 10 to 25 grams or 0.5 to 1 gram per kg. 1 to 12 years of age, you could give 25 to 50 grams or 0.5 to 1 gram per kg, a maximum dose of 50 grams. Adolescents and adults, you could give up to 25 to 100 grams, with 50 grams representing the usual adult dose. In case the child is able to voluntarily ingest, that is the best way of doing it rather than giving it through a nasogastric tube. Though it's very, very difficult to actually take in orally. So how do you administer in the activated charcoal? Now, you can either mix it with powder that you form a slurry, but it's poorly palatable. And in children, you can actually flavor it either with juice or chocolate milk or ice cream to improve the compliance. But again, that is supposed to decrease the absorptive capacity of activated charcoal. It is also available as a suspension along with sorbitol, which may help improve the palatability and additionally act as a cathartic. Now, again, the use of sorbitol and being a cathartic, it can cause electrolyte imbalances, and so it may not be recommended in children. In case you really need to give it, that is sorbitol along with the activated charcoal, please give only 1 dose and not more than that. The other thing is an enhanced elimination, where you want to, enhance elimination of the toxin, where you can give an initial dose of 50 grams, as discussed earlier, 1 gram per kg in children, and you can repeat a dose of 25 grams or 0.5 gram per kg in children every 2 hours. And this way, it also reduces the absorption of the poison into the systemic circulation. And there are 2 mechanisms which may account for such a benefit. One is the interruption of the enterohepatic recirculation that can occur. And also, it reduces the absorption of extant or delayed release formulations which are there. These are some of the contraindications, just like gastric lavage, where you are not very sure about the airway reflexes. And it's a no in hydrocarbon ingestion. Or there is a need for endoscopy in the patient. So please do not give activated charcoal because it can impair the visibility during an endoscopy. And some of the toxins like iron and lithium alkali are poorly adsorbed by the activated charcoal. So there is no role of that in that. Or a presence of an intestinal obstruction, which is an absolute contraindication, or concern for a decreased peristalsis, which is a relative contraindication. So if you have a child that is coming in with iron or lithium, please do not use activated charcoal. So these are some of the indications for use of activated charcoal, where you have carbamazepine and phenobarbital coma. It's supposed to reduce the duration of coma. Dapsone toxicity with significant methemoglobinemia. digoxin and quinine overdose and theophylline overdose, there is a role for using multi-dose activated charcoal. The third way of decontamination is whole bowel irrigation, where you administer an osmotically balanced polyethylene glycol electrolyte solution to induce liquid stool. And this is the way to mechanically flush pills or tablets or drug packets from the GI tract. A nasogastric tube placement is usually necessary for administration. These are some of the indications for a whole bowel irrigation. You have an iron injection of more than 60 milligrams per kg with opacity seen by on the abdominal X-ray, like was shown earlier by the previous speaker. A life-threatening injection of diltiazem, verapamil, lithium, or lead. There can be some slow-release potassium injections also, so you need to use a polyethylene glycol for that, and symptomatic arsenic injection. These are some of the contraindications like an ileus or a bowel obstruction, perforation, clinically significant GI hemorrhage, patients who are hemodynamically unstable, because this can cause a lot of purging and loss of fluids and electrolytes, and so the patient can have hypotension, so be very careful. Or the child is vomiting quite a bit, so it's not possible for us to do this. The dose children 9 months to 6 years is 500 ml per hour. And children 6 to 12 years is 1000 ml per hour. Adolescent and adults 1500 to 2000 ml per hour. And this is continued until the rectal effluent is clear. And radiographic studies may be useful in certain circumstances, example, iron ingestion and body packing, to confirm the absence of the residual toxin. Some of the complications of the whole body irrigation is, bowel irrigation is nausea, vomiting, cramping, bloating. And obviously, like discussed earlier and many times, an unprotected airway, please do not use this. And the whole bowel irrigation may interfere with activated charcoal also when it's administered concurrently, because it would not stay there to have the to absorb the toxins, because it just gets flushing down. So please do not use an activated charcoal when you're doing a whole bowel irrigation. Now, this is a GI decontamination triangle, which you have to look at the risk benefits. Suppose your child comes with a toxic ingestion, you get a good history. What is the time since ingestion? If it's 4 or 5 hours, that means it's not going to be of much use. Within 1 to 2 hours of ingestion, yes, you can take a decision. You need to decide whether it's going to be useful or it's going to be not useful. What are the questions that you need to ask yourself to think whether it's useful? It's a time since the last ingestion. What is the purpose of decontamination? Does the child have any signs and symptoms of toxicity? Or when you look at the risks, are there any contraindications? Is the child's GCS is very low? I do not have the facilities to incubate this child before giving a lavage or whatever. Is there a risk of deterioration if I do a decontamination in the child? So all these things, questions you must ask yourself before you actually start doing it. So finally, the last few slides, I need to give some of the recommendations. The first and most important thing is a protected airway prior to any GI decontamination. And patients may benefit with the administration of activated charcoal in a single dose of 1 gram per kg, maximum dose of 50 grams, particularly if given within 1 to 2 hours of ingestion. Now, that's very important. Please withhold your activated charcoal if you think it's a non-toxic ingestion. The patient presents very late. Poisons which are not bound by activated charcoal, and patients whose risk of complications like aspiration is there, please do not use it. A cathartic, like I told you, like sorbitol, may be administered with the initial dose of activated charcoal, but be careful in children. Better to avoid it. In case you need to give it, just give 1 dose. And a whole bowel irrigation is reserved for patients who have ingested toxic foreign bodies, like I told you, drug packets or a lot of iron, etc. So that is the one that you need to give whole bowel irrigation. As far as gastric lavage is concerned, it is not recommended for routine decontamination. May be helpful if the patient has ingested a toxic amount of a poison and the procedure can be performed within 1 hour of ingestion. And this gastric lavage should be followed by activated charcoal administration unless the agent ingested is not absorbed by activated charcoal. Thank you, sir. I'm going to end my talk now.
Thank you, Dr. Ramakrishnan, for that very lucid and very clear-cut guidelines, which are very not only practical and simple, they were all backed by good evidence and your good experience. And also appreciate your thank you. We appreciate the take-home messages that you could synthesize the most of the important aspects.
Thank you, sir.
Thank you so much.
Thank you, sir. Thank you very much.
Thank you. We will be kindly stay for the maybe taking 2 or 3 questions or whatever is available in the chat box at the end of the next speaker.
Sure, sir. Sure, sir. Thank you.
Now we'll be moving on to Professor Pillai. Professor Pillai, as already mentioned, is one of the standalone departments where he's heading it. He's head of the toxicology division at the Amrita Institute. And he's very well known for his wide experience and his writings. And he's an authority on many of the toxins, especially in Indian situation. May I request Professor Pillai to now start sharing his presentation and start his talk. Professor Pillai.
Thank you, sir. Thank you, all of you, for inviting me to this privileged event. It is the first time I think I'm talking to the pediatricians from Tamil Nadu. I hope I'm audible. If there is
yes,
any.
Sir, you are audible and visible. Very well.
Yes, yes. So thank you to all the office bearers of the Tamil Nadu chapter of Indian Academy of Pediatrics. I feel honored to be here. I would like to start sharing my slides, and I'll stop my video because sometimes that interferes with the audio and with the connectivity. I hope the slide is visible because Dr. Thangavelu requested the speakers to put up their CV as the first slide. I've done that.
Yes,
moreover, I think
visible, sir.
Yes. Moreover, I think most of you really do not know me personally, and therefore the first slide may be a little appropriate in my case. I'm not a pediatrician. I'm not even actually a clinician. I belong to the Department of Forensic Medicine and Toxicology, but I now am totally in charge of the Poison Control Center here. For the last 20 and odd years, I'm in toxicology only. And I'm just an administrative head of the Department of Forensic Medicine and Toxicology. As you will be able to see in the next slide, there is some background noise. I hope everybody can mute themselves. I request everybody to mute themselves because there is some background noise. Thank you. I belong to Amrita Vishwa Vidyapeetham, which is deemed to be university, and it runs the School of Medicine in Kochi campus. I've been working here for nearly 20 years. Previous to that, I was in Kasturba Medical College in Mangalore, which comes under the Manipal deemed to be university. So right from the time I have been here, I've been involved in toxicology. I've set up the Poison Control Center. I'm also, of course, now the head of the Department of Forensic Medicine and Toxicology, but I do not do medico-legal autopsies. For that, there is a separate unit. First of all, let me introduce you to Amrita Institute of Medical Sciences. In a short span of just about 20 years, it has scaled, peaks of excellence, and I'm very proud to be part of it. I'm a little apprehensive also because naturally the expectations are high when you belong to an institute like this. We also recently got NAC AA+ rating, which is the highest for an institute, and very few institutes, I think, in the country have got A++ rating under NAC. So as far as our department is concerned, we have 4 units actually. One is a Poison Control Center, which I manage. Analytical Toxicology Laboratory, also I'm the authorized signatory, but it is actually managed day to day by a lady named Arati, who is very capable. And then we have a clinical forensic medicine unit, which takes care of all the medico-legal services of the hospital, and a forensic pathology unit, which undertakes medico-legal autopsies. In fact, we are the only private medical college in Kerala undertaking medico-legal autopsies, which is a little disappointing because there are so many other private medical colleges, and I think all of them should really step in and perform autopsies because that is the core function of an FMT department. We also have a poison control center that is listed in the WHO Global Directory of Poison Centers for the last 18 years. We have a clinical forensic medicine unit that works in collaboration with the ER. And we, of course, have the analytical toxicology laboratory, which is accredited by NABL, perhaps the only NABL accredited clinical toxicology laboratory in the entire country, which is again slightly disappointing because I think it is a need of the hour. As far as poisoning is concerned, we all know India has the dubious distinction of being #1 in the world with regard to both incidence of poisoning as well as, unfortunately, mortality. And we need to do something about, addressing these issues. This is just a collage of pictures from my department comprising all the units, the toxicology, the clinical forensic medicine, pathology, all put together. As far as the Poison Control Center is concerned, it is an autonomous unit attached to the Department of Forensic Medicine. It has a 24-hour poison information service and an analytical toxicology laboratory, 18 years of PIS, that is Poison Information Service, and 13 years of accredited, that is NABL accredited toxicology laboratory. We are, as I said, listed in the Global Directory of WHO, and we routinely examine samples, biological samples from poisoned or overdosed victims. That may be blood or urine or any other body fluid. We don't undertake forensic samples as far as possible because this is not a forensic toxicology laboratory that we are managing. This is a clinical analytical toxicology laboratory, mainly meant for living victims of poisoning and to help physicians and pediatricians, etc., to manage cases of poisoning more effectively. We don't step into the management aspect directly. As I said, I am myself not clinically trained, but yes, I am very closely associated with the emergency medicine department here in Amrita. We have got an excellent relationship, and it's almost like a symbiotic relationship. Our Poison Information Center is located within the ER, and it is open not only to the staff of the Department of Forensic Medicine and Toxicology, but also emergency medicine. Analytical toxicology laboratory, of course, is a unique kind of thing that is run entirely by the FMT department. These are some newspaper cuttings to show you that the recognition from WHO came very long ago. In fact, within 1 year of starting the center, we were inducted into the WHO directory, which is called Yellow Tox Directory. And this is the NABL certificate to show you that we are an accredited laboratory. So as I mentioned, the Poison Information Unit located in the ER provides information on poisons or poisoning 24/7. We use recognized world-renowned databases on toxicology. We use actually 3 main databases. One from the US, that is Poisindex, which is a very comprehensive software on poisons. We also use one from the UK called ToxBase, and we also have one from New Zealand called Toxins. All put together, I will not be exaggerating if I tell you that we can answer queries on more than 1 million poisonous substances encountered globally. I don't think that in the 18 years that we have been operating, we were stumped for an answer with regard to even a single question. Sometimes it took a little longer, but we have always, I think, provided answers. We are available on phone, on email, on WhatsApp, on the social media, on, of course, snail mail, personal contact. We are available around the clock. And I assure you, if you have any sort of query on any kind of poison or chemical or drug or toxin or poisoning or overdose or envenomation, please do contact us. We also have a very, modest kind of analytical toxicology laboratory, but it is well equipped with the instruments that are required for toxicological analysis, like UV spectrophotometer, high pressure liquid chromatograph, that is HPLC. We also have access to GCMS, that is gas chromatography with mass spectrometry. And we have a tie-up with the Cochin University of Science and Technology here in Cochin, which is referred to as QSAT, which has an advanced instrumentation facility. And we have an MOU with them where we can perform very advanced toxicological testing also, including perhaps the best kind of testing for heavy metals called ICP-MS, that is inductively coupled plasma mass spectrometry. So we are an accredited laboratory. So naturally, we have to be very clear as to how we perform the analysis, how we report, and what kind of instrumentation we use, what kind of protocol we follow. All this is as per international guidelines. We are also part of the WHO group on chemical safety, and we are there in the WHO guidelines for poison control in the latest edition of 2020. So analytical toxicology laboratory, yes, we provide the service to all hospitals, government doctors, private practitioners, not only Kerala state, but also neighboring regions. And whether you believe it or not, we get samples from, in fact, all over the country. We have got samples for analysis even from Kashmir. We also routinely get samples from Tamil Nadu and Karnataka, Telangana, Andhra Pradesh, all these states. We often get samples, as I've already mentioned, even from further north, like Kashmir or Delhi or Punjab, etc. I wish that there were more analytical toxicology laboratories to help us out, because sometimes, we are overloaded with samples, and a few samples we may have to refuse to analyze if we feel that by analyzing the samples, the attending physician is not going to get some additional benefit. We'll come to that if there is time later on as to what I mean by, needless kind of toxicology testing. Sometimes that is ordered by a doctor, where additional benefit is not really available, either by way of diagnosis or prognosis of the case. So this is our new poison control center that was inaugurated recently in the emergency medicine department. You can see a mixture of professionals from both emergency medicine as well as forensic medicine and toxicology. The whole thing is located within a renovated emergency medicine department, which is, believe me, quite state of the art. Now, with regard to the poison control center itself, why is it so important to have it? Because of these reasons. There is, the capability of providing instant information on all poisons, methods of diagnosis, treatment of poisoning, etc., to anybody who would like to know. And naturally, this is going to reduce the mortality, even if not the incidence of poisoning. And if you have an analytical facility along with the poison information service, then that can be an added, kind of bonus, because it can help detect poisons in body fluids and suspected samples to confirm diagnosis, and in some cases, maybe to refute a suspicion of poisoning. We are also here in Cochin very much involved with environmental contamination. We work with government agencies, and we also look at industrial hazards. We conduct lectures on industrial toxicology for the physicians in the industrial sector of not only Ernakulam, but also the other districts of Kerala. We are also part of the emergency management committee of the district. The analytical toxicology laboratory of the Poison Control Center, as I've already mentioned, quite full-fledged. And as you can see from the images here, it is nothing but woman power. Almost entirely, it is staffed by ladies, and it is headed also by a lady. And I can assure you the kind of work that they perform, very meticulous, very, very, stringent kind of protocol is being followed. As I said, as per international guidelines, after all, accreditation means there is periodic survey, there is periodic assessment by the NABL of the Government of India. The WHO is also very much concerned that if you have an analytical toxicology laboratory in a hospital or in a medical setting, it should be accredited so that there is authenticity, there is accountability. With regard to the laboratory that does the analysis, naturally, the purpose is to assist physicians in the diagnosis of poisoning or overdose. And I've already talked about the equipment that is available. We have basically, simple kind of equipment, right from thin layer chromatography, that is TLC, to color tests, which are mostly bedside tests. And I think even physicians themselves can do this bedside of the patient, wherever the patient is admitted. And we have an analytical toxicology certificate course for such purpose, which is temporarily suspended because of the pandemic, but we hope to resume that sometime this year. We also have the other instruments that I've already spoken about, including spectrophotometry and gas and liquid chromatography. We usually test body fluid samples like blood, urine, sometimes stomach contents, which may be aspirate or vomitous. We discourage stomach wash samples because, really speaking, we are against stomach wash. I'm very happy to hear the previous speaker say that there is no real evidence to support routine gastric lavage in poisoning. And we believe that totally, as far as Amrita is concerned. We rarely do stomach wash in poisoning cases. We also undertake analysis of water samples, food samples, medicinal samples, etc., for contaminants or adulterants. And with regard to the functioning of the laboratory, yes, we try to make the report of any kind of analysis available as fast as possible, because after all, these are clinical cases. It is not forensic case where some, a dead body, you take, viscera and you're performing the analysis. There, maybe you can take your time, but not here in a clinical case where it is very important that the results are made available as fast as possible. So we try and make it available within a few minutes to hours. Sometimes it may take days, especially if it is to do with some kind of toxin like a heavy metal, which the process itself is such that it will take several days, sometimes up to a couple of weeks. We make sure that the report can be accessed remotely by computer, and if you want a printed copy, it will be signed by the analyst and it will be supplied separately. If you have given the address along with the request, this will be routinely done. And if there is any kind of issue with the report, because believe me, toxicology report is sometimes not very straightforward. It requires a little bit of analysis to interpret correctly. And if there is any kind of issue for the physician, we are always ready to interpret the report correctly. And any kind of queries are possible to be addressed over phone or email, personal contact, and any other mode of contact that is convenient for the doctor. The common tests that we undertake here in our laboratory include number one, tox screen, preliminary kind of screening for common poisons or drugs. When nothing is known, we do it in stages, stage 1, stage 2, and a full tox screen, depending on the requirement of the physician as to whether he has some suspicion or he has no suspicion at all as to what kind of poison is involved. We also have a very good substance abuse screen for all common substances of abuse, including opioids, cannabis, cocaine, amphetamines, benzodiazepines, barbiturates, designer drugs, and so on and so forth. We have got a panel which is very effective and can detect drugs in very minute quantities indeed. Aside from this, we also have, of course, group tests, which may comprise pesticides, heavy metals, alcohols, inhalant gases, all kinds of pharmaceutical drugs, including sedatives, narcotics, anticholinergics, analgesics, antipyretics, pyretics, steroids. This is just an eye view. We have a number of tests which cover almost any kind of toxin that you want analyzed. So we can also do individual poison or individual drug testing from important groups like the ones listed here. And of course, cholinesterase is very popular kind of test that we routinely do. All these are done in our laboratory. Now the question may be asked, are all these tests done by sophisticated instrumentation? Absolutely not. We use very simple kinds of tests, and most of these are color tests. Sometimes we go on to thin layer chromatography or spectrophotometry, and in a few cases, we go to kit-based assays and also high-performance liquid chromatography. So you can see here Much of the testing is basic and simple tests. That does not mean that these tests are not authentic. They're extremely sensitive, specific. There may be some drawbacks, but we mentioned those very clearly in our reports. We follow a format that is internationally accepted. There are two sides to every report. On the, the main side, there will be the result of the analysis. There will be the method that was used that is mentioned. There will be also a remarks column as to how to interpret the report. And on the reverse, there is a disclaimer, as to what kind of problems may be encountered with the particular test, what kind of false positives you may expect, false negatives, what kind of problems may be there with regard to interference, all those kinds of things. So it's a full-fledged kind of report, and we conceal nothing. Everything is available to the doctor, whatever he wants to know, right from the methodology to the person who is doing the analysis, to the time taken, to the cost involved. Everything is clearly laid out, and that is part of the accreditation process. Now you may ask as to why don't we do advanced kind of testing? Why do we stick to only basic tests? Because you see, this is not a forensic toxicology laboratory. This is a clinical toxicology laboratory. We should be very careful about the costs. Already, most of the time, the patient or the patient's attendants are distressed. Many cases of poisoning are deliberate ingestion because of suicidal intent. Some are accidental injections, maybe involving children, but in most of the cases, we find it's a kind of tragic scenario. So we should not really impose additional expenses by doing unnecessary testing or unnecessarily high-end testing. And that is why we stick to most of the time basic tests, which are inexpensive, easy to perform, quick. Basic laboratory setup would do, easy to interpret, and if at all we require to do advanced or confirmatory testing, then we certainly will consider that, interact with the physician concerned, and only then go ahead and do it. Please understand that advanced testing does not really mean that it is better testing. Sophisticated chemical analysis is not always preferable for the following reasons. Number one, some poisons may not be detected even by the most sophisticated instrument. So why spend money unnecessarily? Number two, traces of random toxicants may be picked up, leading to confusion. This has happened in one or two sensational cases in Kerala. I wish I had the time to go into it. Unnecessary kind of confusion was caused, a lot of delay, lot of police time was involved. These were forensic cases, and that is why it is our view that never you should do unnecessary kind of high-end chemical analysis. And then you also have problem with regard to qualified or experienced staff, because high-end equipment means you require trained staff. And I've visited sometimes laboratories which have high-end equipment which are lying virtually idle because the person responsible for undertaking the analysis is not there, and the instrument lies unused. Finally, the most important point is the results can be incorrectly interpreted if you go for very high-end testing, because believe me, the results can be extremely confusing. And unless you have a computer kind of thing attached to the analytical instrument, which helps you resolve these kinds of confusion, the interpretation can become virtually a chaotic kind of nightmare. So because of all these reasons, sophisticated chemical analysis is not really preferable for clinical toxicology. It may be all right for forensic purposes, because after all, a court where the case is tried may require all kinds of details in order to be sure that the analysis was correct and that it was a case of poisoning with a particular substance. Now, I would like to wind up by saying that the WHO is taking up the incidence of poisoning in India, that is so terrible, very seriously. And I was recently in Edinburgh for a meeting for reviewing, the guidelines for poison control, which have been in operation for a long time. And there was a need to review and make them even more, tighter and stringent, and also help countries like India build toxicology centers of excellence in order to bring down the morbidity and mortality. I was mainly involved in these guidelines with regard to analytical toxicology. In fact, I was virtually the only person from Asia for analytical toxicology. So this is how the future of poison control centers looks like in India. There is a plan for making a consortium of poison control centers of Southeast Asian region through the WHO. There is a attempt to network all the existing PCCs in India, and active encouragement to be provided to institutes and hospitals to start similar centers, preferably along with toxicology labs. Creation of indigenous software that will take care of locally available poisons and not really waste time on poisons which are rarely encountered in India. Create antidote banks, create toxicology library, and set up a facility for accreditation, create a membership in national and international societies of toxicology, and make sure that the people in these centers, poison control centers, attend CMEs and conferences on toxicology regularly, and also, if possible, organize conferences and seminars on toxicology, all of which I may mention at the risk of sounding immodest, we are doing right here in Cochin. So with regard to the time available, I thought that is all that I would say by way of an overview of the Poison Control Center here at Cochin. If there are any questions or queries, I think we can take them up later as per the organizer's discretion. Thank you very much.
Thank you, Professor Pillai, for a wonderful overview, and also what's happening right within our vicinity, our own neighbors. So many advances, so many things which are happening in our own neighborhood. So this is really an eye-opener, and also to know the scope and extent, as well as the how it is to be used for all the concerned persons, the stakeholders. It is not just you're very rightly said that ultimately the benefit should go to the persons who are suffering. So I really laud the way you have put it, and also the altruistic and also the scientific temperament behind the whole venture. Thank you so much for that.
Thank you, sir.
And you're telling something.
No, I just was saying thank you, sir.
Okay, thank you, sir. Dr. Tavelu, would you like to put up the questions now? How do you want it?
Yes, yeah. The lectures will complete
you
later.
can just
have to wait for a long time. From starting from Professor Pillai himself, I'll go reverse. Sir, you have not provided the contact details, and probably many of us like to know how to transfer the samples. Those things will be available on your website, or like a blood or urine.
So can you just put it in the chat box? Website or anything?
Contact details, website or
yes. Actually, it is very easy to do that. All one has to do is to Google Amrita Hospital in Cochin. There's a link in the main website of the hospital to the toxicology laboratory, where all the details are mentioned as to what kind of samples we accept and how they should be preserved and sent. We also have put up the complete menu of tests, in the website at the toxicology, link. We also have all the contact, numbers and things like that mentioned there. So I don't think there should be any problem at all. And if anybody has got any kind of personal query, all he has to do is to remember my name. My name is Dr. V.V. Pillai, DRVVPILLAY @gmail.com is my email address. And you can mail me directly. So I felt that was unnecessary. That is why I have not put it up. Amrita Hospital website is easily, accessed. And once you get into that, to go to toxicology laboratory is absolutely no problem at all. All the details you require are mentioned there, including contact details.
Thank you, sir. Thank you, sir. And Professor T.V. Ramakrishnan, a simple question only, whether the question about the availability of charcoal, which I also mentioned is available in the wholesale markets. 2 kg costing around 500,000 rupees. Shelf life is long, 2 to 3 years.
Yes,
TV Ramesh, anything to be added to that, sir?
No, sir. Yeah, it's commercially available also, sir. Yes, sir.
Then using aluminum phosphate poisoning, coconut oil.
I think there have been a few studies where they actually are using a vegetable oil, sir. And these are just random studies, vegetable oil, and somebody even adds bicarbonate to that when they give the gastric lavage. But again, these are just a few studies that have come up. But it's very important to note that use potassium permanganate basically in aluminum phosphide poisoning, 1 in 10,000 dilution. which will help to prevent these issues.
Okay, sir. Thank you, sir.
Thank you, sir.
Dr. Srinivasan, the question is about the methemoglobinemia. Whether GC-speed, of course, you have answered in the chat box. For the sake of others, I'm just asking whether GC-speed level was done before giving the IV methylene blue. Dr. Srinivasan, any of for him?
We did GC-PD level for that child, sir. But since child was hypoxic, we didn't wait for the results. We gave methylene blue. G6PD level was normal, sir, within normal limits.
Okay, I think thank you. We have covered all the questions. One more question is how.
Is it audible, sir?
Yes, audible. You just told the G-speed level was normal, but we got a message from you. And then how to administer N-acetylcysteine? There is one question. Oral or IV? Professor Ramakrishnan or Dr. Srinivasan, either one of you. Administration of N-acetylcysteine.
N-acetylcysteine dose is so 150 mg per kg given over a period of 15 minutes, followed by 50 mg per kg given over a period of next 4 hours, followed by 100 mg per kg over a period of next 16 hours, sir.
I think it's available in the standard textbooks also.
Yes, sir. It's available in Nelson, sir.
Sir, over to the chairperson, sir. I think all the questions I have covered.
Dr. Ramakrishnan, I have a question.
Yes, sir.
Is there any particular position the person has to be right lateral or left lateral when you do a lavage? Or these are all just don't have any real significance? If at all you believe in lavage, as Dr. Pillai was telling, some people don't believe in lavage at all. So if at all, are there any studies or anything?
I think this was done especially when they were using the gastric tubes much earlier, sir. Nowadays, we are stopped using the gastric tubes even where I work. It's been almost 20 years since we used the red rubber gastric tubes. As far as the Ryle's tube is concerned, I think it can be put in the supine position. We do not actually keep the patients in the left lateral or the right lateral positions unless the patient is actively vomiting. And if you're not very sure about the airway, we usually go ahead and intubate these patients before we actually put in a Ryle's tube. So we really do not put them in the lateral position when we are inserting a Ryle's tube, sir. But in case the person is actively vomiting, yes, definitely I would do that.
Yeah. Ramakrishnan, when we were working in the emergency room in ICH many times, I'm talking about 2 decades back or 3 decades. So we used to preserve the sample and other things, but we didn't know what to do with the samples. We thought that the medico-legal cases, you have to preserve all the samples and other things. Does anybody really do all this toxicology, this thing in Tamil Nadu, or do you do it for some cases? And where do you do it, if at all you need?
Not really, sir. We do not do those sampling in Ramchandra. We just preserve the samples at the Forensic Sciences Department. We send it there, but we actually do not do any toxicological screening. For some cases, yes, we were doing the urine toxicological screening, but then we have stopped doing all that, sir.
Sir, the PRC, I think when we both of us are working there in ICH, and our toxicology lab in Beach Road attached to the IG office, they used to do it, gastric lavage. Most of the time we send it, they identify dapsone or other substances and identify it. Afterwards, after 2009, then started asking what medicines you are supposed to check. Then that becomes $1 million question. So now I don't think it is available.
Yeah, I don't think we are sending some. We were doing that earlier, sir.
Earlier,
said, but I don't think we are sending it anymore, sir.
Srinivasan, are you doing it now? ICH, are you sending samples to toxicology lab? Srinivasan, ICH.
Yes, sir. Recently, 2 weeks back, we sent one sample to a child with a suspected poisoning, sir.
Okay.
Hello?
Yes, listening. Yes, listening.
Sir, is it audible?
Audible.
Sir, that sample was positive for barbiturates and benzodiazepine.
Okay, I think they are doing for medico-legal purpose, I think.
Yes, sir. Yes.
For management purpose, probably you do not need, and you will never get the this thing reports in time. So it may be a rare case where you may need it. Probably you can preserve for some time and look at the flow of the case and then decide.
And most of the patients come with tablet overdose. So we actually, for most of the patients, we actually know what has been consumed.
Exactly.
These days, things are changing actually.
Yeah. Thank you, sir. Can we conclude, Dr. Thangavelu?
Yes, sir.
Yeah. So once again, we thank on behalf of IAP TNSC all the speakers, Dr. Srinivasan, Dr. T.V. Ramakrishnan, and Dr. Pillai for the wonderful exposition. Within the time limit which we are given, we are really shown that what are all the wealth of information we have to know to manage effectively these children who come with problems like poisoning. So I conclude here. And Dr. Thangavelu?
Yes, I will move on to the first round, which you are going to moderate, sir.
Yeah.
You can.
So shall I start?
You can share the slides, sir.
Yeah.
So for all the panelists, the questions are to be asked as per the alphabetical order. So you can probably, you will find your order as per the alphabetical order.
Please let me know if the slides are seen.
The slide shows.
Is it visible?
Yes, sir. Visible and audible. You put it in the slide shows.
Yeah.
Yes, sir. Now slide shows.
Thank you once again, IAP TNSC and the CME coordinator, Dr. Thangavelu, for this opportunity. So we are going to have 2 rounds of case scenarios to our expert panelists, and who are already as introduced. Dr. Akhila Devi, Dr. Debashish. Dr. Akhila Devi is from Madurai, am I right? Dr. Thangavelu?
Yes, sir. Madurai, Rio Hospital. Madurai.
Rio Hospital, Madurai. Dr. Debashish is from CMC Belur. Dr. Jayakrishnan from Kozhikode. Dr. Lakshmi from Child Trust. Professor Pillai we have already heard. And Dr. Punita from Dharmaburi. Dr. Rajkumar from SRMC Chennai. Dr. Sarda Sati from Mehta. And Dr. Senthil Kumaran from Tirupur. So, just wanted to say all of us know this. Okay. So everything which is in excess probably is poison. So every one of us has some element of poison in us because we never stop what we need only. But luckily it doesn't harm us much because we somehow know the limits. And this photo also you saw in Professor Pillai's lab. Okay, Paracelsus is one who is attributed to making this statement. And isn't everything, and there is no thing is without poison, is the dosage which makes it either a poison or a remedy. And Dr. Srinivasan has actually given the 10-year statistics. What I have is only for 5 years. Just for the comparison, I have put the statistics on, from US for 1 year also. So still the question asked by one of the, I think Dr. Vishnathan asked, are we still seeing kerosene, especially in the government hospitals and all over India? Still the kerosene is ranked as the #1 poison in children. Probably because many of this thing are from the lower socioeconomic status. But probably when we are discussing kerosene, we will ask the other panelists whether they see a lot of cases in their own institutions. And these are all the other things: mosquito repellents, detergents, thinners. These are all become almost now household items. And organophosphates, other pesticides, rat killer, paracetamol, iron, anticonvulsants, and cough syrup. These are all the topmost things. And I have marked in the bracket the mortality, kerosene and organophosphorus, and for the number of cases, the rat killer mortality is high, paracetamol, and the Acute also Dr. Srinivasan has mentioned. If you look at some of the statistics available from other institutions, one was available from Chandigarh for about 12 years, that is before 2000. There was no mention of button battery or paracetamol. So things are really changing. It's not the same poison which are going to be there for every decade. Now, as you are rightly seeing, a lot of hand cleansers and other things are all coming to poison after the COVID era. Okay. So one has to be aware of what is the prevalent poison situation in their own places. Now we will go to the first case scenario. And this is a 1.5-year-old child. The child is developmentally normal, brought to the history of breathing difficulty, induced vomiting after he consumed an all-out mosquito repellent liquid, which is there now almost everywhere, every house. Unknown quantity, around 8 to 10 hours before the arrival. On arrival, the child was lethargic, tachypnic, dyspneic, There was low saturation on room air. There was no evidence of shock. We had made a diagnosis of respiratory distress. After some time, the child also developed seizures. That settled with anticonvulsant. Can I have the first, what is the management and what causes the problem?
Good evening, sir. Okay, with a heartfelt thanks for this privileged opportunity. And this child, in the scenario, being only having a respiratory distress with no other complications, we made an initial stabilization. The child was given initial stabilization and admitted in PICU. And as the seizures were controlled, there were no further seizures. And the child was initially given an NIV support, but the child did not improve. And later we intubated the child, and other supportives and antibiotics were given. The chest X-ray which was taken showed the features which is shown. It's like more of an aspiration pneumonitis with ARDS, which was managed accordingly. And the investigations were showing leukocytosis with positive CRP and raised ESR also, with other RFT and LFT being normal. So this particular complication for this child mainly was attributed to the induced vomiting. Usually this mosquito repellent poisoning, as told in the previous lectures, it's very common, being the second and third most common. This usually have a CNS and GI symptoms alone. But when we see a child with cardiopulmonary involvement, it is mostly due to the iatrogenic or inflicted things which were given by the parents or caregivers. That is, they induce vomiting, they delay the time, and then they bring the child to our ER. So this particular child, the complication is mainly due to the aspiration pneumonitis, which further progressed to ARDS and shock, and which had a stormy course. But luckily, the child improved with the supportive treatment, and the child came out very well.
Thank you, Dr. Agila Devi. As mentioned by Dr. Agila Devi, luckily, though it's a very, very frequent happening nowadays, most of the children do not have much of a problem because the volume which is there is usually very small. What is there in that mosquito repellent container? There are two components in this. One is the pyrethroid component. Another one is a solvent which is used, which is usually a hydrocarbon. So they can have two types of presentation. One can be something like a hydrocarbon, especially with as suggested with induced vomiting. They can have a predominantly a respiratory component, or they can have, due to the pyrethroid component, there can be CNS complications also can happen. So there was a review by a set of people in Indian pediatrics where they started seeing more number of cases, and they mentioned that about this solvent which is causing a problem in the majority of the cases. So they behave more like a hydrocarbon poisoning. So both the manifestations can be present. Am I right, Dr. Agila Devi? Do you agree?
Yes, sir. Yes, sir. Yes, sir.
Okay. We will move on to the next scenario. This is Dr. Debashish Adhikari from CMC Vellore. He has seen a child, a 5-year-old child, was brought to the emergency room with lethargy, vomiting, and unsteadiness. He was conscious with a normal blood pressure, and the respiratory rate was a bit high, normal temperature, pulse rate also was slightly high. Oxygen saturation was 90% of the room air. He had cyanosis, and he was also ataxic, and the pupils were equal, reacting to light. Reflexes were brisk, and the tone was increased in all 4 limbs. If you have seen a child like this, Dr. Debashish, what will be your initial thoughts? Then we will go to the clinical findings, something more in investigations.
Yes, sir. Because we have seen that a stable child with cyanosis with this type of clinical pictures, always what happened, we suspect this child could have drugs or something which caused methemoglobinemia. So we did immediately a ABG, and ABG found the PO2 is 84 and hematocrit was 28. And we started taking details history, and we found that father is a case of leprosy, and father is taking a Dapson. So, but father was not very sure whether this child has taken Dapson, But the clinical picture suggestive of methemoglobinemia, which is very commonly associated with dapsone, then initially we thought it's a dapsone toxicity which caused methemoglobinemia.
Yeah. What do you think could have been the possible sequence of events, and how do you assess and manage?
This child, what happened, came to us with initially cyanosis only, and so we thought that we'll do methemoglobin level, but anyhow we started the treatment with ABCD, airway, breathing, circulation disabilities. He came immediately. We gave him stomach wash, even activated charcoal, and we started methylene blue because the features were suggestive of more than 20% ingestions. So that's why we started methylene blue for this child. So this accidental ingestions of dapsone is very common because most of the time dapsone used for different dermatological conditions, acne vulgaris, ITP, and leprosy. And initially what happened, the presentations may not be very serious, but if you don't fail to diagnose methemoglobinemia later on, it can cause severe complications.
That's right. Most of the time, the history of injection may not be coming. It's only later, after you suspect and repeated probing, the parents say that, because many of them also it's a stigma. They may not be actually even there. Many times even the spouse may not be knowing what tablet the husband is taking. So yes, many times later, because of the critical nature of the child, the parents, one of the parents may actually accept that, yes, they are taking this tablet, some of them are missing, or some such suggestive history may be forthcoming. Many times you, because of your clinical suspicion, you go back and then you confirm the diagnosis. So what are the special considerations? Yeah, please go ahead.
Very careful about, yeah, we have to be very careful about the pulse oximeter, sir. The pulse oximeters will be relatively high, but they will have a severe amount of hypoxia. And another condition called G6PD deficiency. So if the child has associated G6PD deficiency, the methemoglobinemia may not respond to methylene blue. And in that case, we have to consider like exchange transfusions or hyperbaric oxygen therapy. So you have to be very careful about that.
Dr. Srinivasan also in his talk, he brought out this case scenario where actually the child, even the cyanosis was masked because of the G6PD deficiency, and the child with an aspirin ball, this thing had hemolysis and low hemoglobin. So these are all the things sometimes can put you off. So yeah, an astute clinician who has been seeing the emergencies, when they put all the things together, sometimes they come to a conclusion. So this is really requires some thinking in some of the rare cases. What are the drugs, what are the chemicals which may cause this acquired methemoglobinemia, and how do you go about assessing its severity? And you said the pulse oximetry may not be much this thing, or sometimes may be confusing. Then how do you go about in confirming?
So what happens, sir, we have to take a detailed history first and make sure that the child has not taken those common things which is available commonly, like nitrites and nitrates, nitric oxide and sulfones, dapsone, local anesthetics like benzocaines, aniline dye, then pyridium, and then sulfonamides. These are the things we have to be very careful and take detailed history. And especially you have to be careful whether the child has taken a dapsone product. Even the dapsone is given as a skin ointment, and a case report has shown that even the methemoglobin level is more than 20%, which has to be treated by this special treatment, methylene blue. And we have to be very careful about that. If the methemoglobin level is more than 15%, and they may start with cyanosis, and if it's between 20 to 45%, they'll have a headache, lethargy, tachycardia, and dizziness. If it is more than 45%, they'll have dyspnea, acidosis, seizures, arrhythmias, heart failure, and coma, and more than 70% associated with high mortality rate. So in conclusions, I can say that any case presenting in pediatric emergency department or any emergency department with cyanosis and breathlessness not responding to oxygen must be suspected as a case of methemoglobinemia. And dapsone commonly used drugs in the treatments of various dermatological conditions and should be kept out of the reach of the children to prevent significant mortality and morbidity from this disease.
Thank you, Dr. Debasis, for bringing out that case, which again reinforced what Dr. Srinivasan was also discussing in his initial presentation. So these are all some of the things, some of the substances which can be causing, as already mentioned. And Dr. Srinivasan also mentioned about the benzocaine oral gel, and also the local anesthetic cream like Imla can be cause of a problem. Sometimes in a child with a cyanosis, when you take the blood, you may actually see this change. Like a normal blood you can see, and this chocolate brown color of the blood which is got methemoglobinemia. You don't get that usual bright red color. So that may give you again a clue. You put on a filter paper also, you can appreciate it very well. Sometimes that can also be a clue. And also when you take the pulse oximetry, all may not be having this co-oximetry. Some of this advanced co-oximetry, they can straight away give you the methemoglobin and sulfahemoglobin also, other than the oxy and deoxyhemoglobin levels. But all may not be having this. But when you see this discordance between the what you see in the saturation through your regular ABG and what you see through your pulse oximetry, pulse oximetry doesn't show any much of change at all. With respect to the severe cyanosis, it will be showing only around 85%, because the methemoglobin doesn't differentiate between the different wavelengths by which the pulse oximeter works. So it shows almost a constant value. So even with a child with a cyanosis of 35% or 40%, you will be getting only around 85%. So this is the one which has got a ability to pick up the methemoglobin also. You can see the levels are 35. But if you see the pulse oximetry saturation, it is just around 86%. Okay. So there is a discordance between the what you see between this pulse oximetry as well as what you see through the ABG. That is known as saturation gap.
Sir, can I add one point?
Do you want to add anything more?
Yeah, sir, can I
yes,
add?
Dr. Arvind.
There are stray reports that plasmapheresis may be useful in refractory case of methemoglobinemia. Nowadays, most of the ICUs have got CRRT machines. So plasmapheresis also may be an option. It is also being tried. If you remember, sir, when we did the exchange transfusion of one child who had a very high meth levels, but it was not effective. So probably plasmapheresis may be an option. Thank you, sir. That's all. Thank you.
Thank you. So this is one of the conditions Dr. Ramakrishnan also was mentioning. You may have to do enhance activated charcoal. Sometimes you may have to use repeatedly because of to interrupt the enterohepatic circulation. So it may keep on coming into the intestine and getting reabsorbed. That is one thing you can remember in Dapsone. Second is the other thing which you have to remember this. And methylene blue, G6PD children, you may not be able to use, or you cannot use repeatedly. So that is another constraint. So those patients sometimes plasmapheresis or hyperbaric oxygen and other things may have a role.
Sir, 1 minute, sir.
Please.
Sir, regarding this co-oximetry will not be available everywhere, sir. Especially in a rural area when they are practicing. As you rightly pointed out, if ABG is there, the pulse oximetry, the oxygen saturation gap can be given, or filter paper test can be done. If still it is not, you are not able to come to a conclusion, we can do a cooking test, sir. Just take the blood sample and keep it in a hot water. If the brown color, chocolate brown color will be changed due to the oxidation, it will be changed to bright red, sir. Especially from the March to May, we regularly get more cases in our hospital. Even now, I have 3 patients with methemoglobinemia in my ICU.
Why, Dr. Sendil, March to May?
This is flowering season, sir. This is a flowering season. Especially for the mango, the flower should not fall. They start from this November to March. They used to spray this so that the flower will be there and turn into as a mango, sir.
Nice, very useful and interesting observation. Thank you so much. And we will go to the next one, which will be to Professor Jayakrishnan. Jayakrishnan, this is an 18-month-old boy consumed unknown number of iron tablets prescribed for the pregnant mother, which also another case scenario which she had already. Child had vomiting, doubtful hematemesis and drowsy, cold peripheries. The breathing was normal, sensorium was normal. Generally, how do you go about in assessing a child with iron poison? They just come with a history that the child has taken some number of tablets, not sure about how many. What are the management principles and how do you go about assessing? Dr. Jayakrishnan. Dr. Jayakishan, please unmute. Are you there?
I don't see him there, sir.
Okay. So probably we'll come to it at the end if he's able to log in. Shall we proceed with the next one?
Yes, sir. I'll just call him, sir. In the meantime, you can go for the next.
Yeah. This is for Dr. Lakshmi.
Yes, sir.
Yeah, Dr. Lakshmi, this is a 10-month-old child with the, as usually happen in many times with the paracetamol poisoning in our situation. The mother had been giving the paracetamol syrup, the drops instead of syrup, but the dosage which was mentioned for the syrup was given the drops. So the total dose worked out to be more than 200 milligram per kilogram per day.
There, sir. No.
Yeah, we'll come to him later. The child was clinically stable with just a mild rise in transaminases. So how do you go about these children with, unfortunately, with a good intention, the treatment of the fever, but resulted in this type of problems? Dr. Lakshmi.
Yes, sir. Actually, this is the history-wise, this is repeated supratherapeutic dose that is more than 90 mg per kg per day on consecutive days. So this is really hepatotoxic. So this really needs NAC therapy. As far as paracetamol toxicity is concerned, so any single dose more than 200 mg per kg or adolescents and adults, it's more than 7.5 to 10 grams. In this child, it is more than 90 mg per kg per day for consecutive days. So this is really repeated supratherapeutic dose. From the time of onset, for first 24 hours, child will develop GI symptoms, and next 1 to 2 days, child will have elevation of liver enzymes, as in this case, and then 3 to 5 days, there is peaking of liver enzymes and acute liver failure sets in, and child goes for multi-organ dysfunction and death. And then next is resolution. Where the complete recovery takes place. Either they will completely recover or go for transplantation. So, in this child, already liver function test was done, and then sir has told that child has got elevated liver function. So, this definitely comes into the category of hepatic injury. As far as treatment is concerned, it is prophylactic. We'll say when the child has just come with acute toxic ingestion, but in this case, the child was given repeated toxic doses, that is in the supratherapeutic for more than few days. So this comes under that is cumulative overdose. So this child has come with a hepatic injury. So I will definitely start N-acetylcysteine. We should not be waiting for progression of hepatic injury to set in. So really, even with mild elevation of liver enzymes, even though the paracetamol level may be normal also, but I will definitely start N-acetylcysteine in this case. We have to somehow prevent the child going for acute liver failure. So this is indicated. So that is IV N-acetylcysteine I will give.
Right. So only for a single large injection, you use the Matthew nomogram.
Yes,
send it 4 hours after that, single injection, and look at the levels. Otherwise, like in this case, which most commonly happen in our situations, repeated dosage, then you have to go by the clinical picture, the total calculated dose, as well as the liver enzymes, and take a decision based on that. And N-acetylcysteine questions are asked, which is already answered by the previous panelists. So we will not repeat it. Dr. Jayakishan is available. Can we take up his case?
Sir, he's getting upgraded to panelist, sir. Probably after one question, you can call him, sir.
Sure. We'll go to the next case scenario.
Okay, sir. I can
join, sir.
Yeah, I'm available now, sir.
Okay.
Yeah. Thank you very much, sir.
So, sir, your question is regarding the child who's brought with iron tablet injection.
Okay, sir. Yeah.
Unknown number. And how do you assess such children, and what are the principles in management?
What we see in iron tablet ingestion is generally they have to begin with gastrointestinal symptoms like vomiting, abdominal pain, and sometimes loose stools also. And a significant ingestion is suggested whenever GI symptoms are there in the first 5-6 hours. If you see a child who has no gastrointestinal symptoms in the first 6 hours, it is unlikely that she or he is going to have a serious toxicity due to iron poisoning. But then this may not be applicable in situations where the child has ingested an enteric coated iron tablet, which is not usually the case. Usually it is an iron that is easily absorbed. It's not an enteric coated tablet. So they generally have symptoms within the first 6 hours. The important point to remember is that this particular phase of initial gastrointestinal symptoms is followed by a relatively stable phase for about 24 hours, like 6 hours to 24 hours is the time when they are relatively stable. But then it's very important that you assess these children periodically to look for subtle features, like maybe there may be increased rate of breathing, like acidotic breathing could be there, which is sometimes missed. Subtle features of poor perfusion may be there. And if you do a blood gas analysis, either venous or arterial, you might see metabolic acidosis, which again suggests a serious toxicity. So it's very important that you should not miss this phase, because we have seen cases where children were reassured and sent home after they developed vomiting, abdominal pain following iron ingestion. But then child was brought on the third day with features of multi-organ dysfunction, and we could not save those children. So it's a dangerous thing that you send them home after the onset of GI symptoms, when some symptoms subside. That's very important. This apparent stabilization time is something which you have to be very careful about. And then that is followed by the other phases like shock, acidosis, and then they develop multi-organ dysfunction, and that's how that progresses. And I can recall our experience during the last 10, 12 years about children getting admitted in our hospital, when there used to be a program where Anganwadi teachers were given iron tablets to supply to the pregnant women to go to the Anganwadi. And what happened, this happened in 2007-8 initially. Can you show that graphs there?
So yeah.
Yeah, that is, the first two are 2007 and 2008, where we had many cases. Almost 28 cases were admitted in those 2 years, and we had 4 deaths those 2 years. And following that, we actually started counseling the sessions for all Anganwadi teachers, and you can see the dramatic reduction in the number of cases happening after that. The first 2 are 2007 and 2008, and the last one is 2019. The year is not coming there in this particular slide. But then you can see the dramatic reduction in the number of cases, even though there is a slight increase in 2019, where actually the government introduced a new program, that is weekly iron folic acid supplementation program now. And all the children are sometimes having this poisoning now, because they usually are given these tablets by the class teacher to consume it every week. But what they do is they have some kind of a bet or something, and the students, one person will eat all the tablets. And that kind of incidents we had 3-4 times during the last few years. But then no deaths since 2008. It's a dramatic reduction in the number of deaths also.
Do you want to go ahead, Dr. Pediatrician, regarding the management?
Yeah. And then regarding treatment, you need to decide when to start, when give specific treatment, that is chelation with deferoxamine or not. So you have to be very careful if there is a history of ingestion of more than 40 milligram per kilogram of parenteral iron, or if you are not sure how much quantity of iron the child has consumed, or any child who is symptomatic also, as we already discussed. And basically, the steps involve, apart from supportive care, bowel decontamination using whole bowel irrigation, and the specific antidote, that is deferoxamine. And generally, whole bowel irrigation, we routinely do that in children who have visible tablets in the X-ray. And if there is a history of ingestion also, more than 60 mg per kilogram of ingestion, or if you can actually calculate the approximate amount of iron ingestion by looking at the number of tablets seen in the X-ray. And deferoxamine you generally give for all children who have severe GI symptoms, any child who is having acidosis, metabolic acidosis, any other serious presentation like coma or seizures. If iron tablets are visible in the X-ray abdomen. If the serum iron concentration is more than 90 micromolar per liter, or if it is more than 60 and the child is symptomatic. Generally, you do this serum iron level at about 4 to 6 hours post ingestion, because beyond that time, this iron gets actually distributed in other organs. So you may not be able to actually estimate the actual amount of serum level of iron. So it's about 4 to 6 hours. If it is an entry-coated tablet, you assess the serum iron level at about 8 hours. And how long to continue this treatment is something, again, it's till the child becomes symptomatic, till the acidosis is resolved, till the serum iron level is less than 60, and urine color once it returns to normal. But then the Win-Rose color, so-called Win-Rose color that develops once you start chelation therapy in these children, it's not a very useful finding, because many children who are actually ingested a very large quantity of iron also may not be having a Win-Rose color to the urine. So that's not very useful. And it's important that you need not continue deferoxamine treatment for more than 24 hours, because deferoxamine has got its own adverse effects also. It can actually cause sometimes hypotension. It can cause lung injury, which can result sometimes in ARDS also. So generally, treatment is not continued for more than 24 hours.
Thank you, Dr. Jayakishan. We will go to the next case, which is to Dr. Punita. Many household poisons, but we'll take camphor because of so many festivals occurring. So the camphor poison is one of the commonest. And many times children come with an acute condition. So what are the clinical manifestations and the management principles? Dr. Punita. Are you there, Dr. Punita?
Sir, am I audible?
Yeah, you are audible. Please go ahead.
Yes, sir. Good evening, sir. Because camphor is easily available and because of its attractive shape and small children have the tendency to put everything in the mouth, it is one of the common poison encountered. Symptoms can start as early as 5 minutes and peak effects by 90 minutes. Usually the symptoms are nausea, vomiting, agitation, hyperactivity, and seizures. Usually the child presents with seizures and rarely status epilepticus. The symptom starts by taking 30 milligram per kg of camphor. The fatal dose is 50 to 150 milligram per kg. The peak plasma concentration reaches by 1 to 3 hours. The toxicity usually resolves by 24 hours. Next slide, sir. Coming to the pathophysiology, it is a rapidly acting neurotoxin. Initially, there is excitation followed by depression of central nervous system. It is oxidized and conjugated by liver and excretes by kidney. The site of action is intraneuronal. It blocks the oxidative cycle and leads to tissue anoxia. Treatment is mainly supportive and symptomatic care. You have to stabilize the airway, breathing, and circulation. We have to control the seizures by using benzodiazepine. If there is topical exposure, in case of any local application of ointments or any Vicks VapoRub like that, we have to wash with soap and water. There is no role for activated charcoal or emetics or gastric lavage because camphor is absorbed rapidly from the stomach. There is no specific antidote for this. In case of asymptomatic patients, they need to be observed for a minimum of 6 hours. Thank you, sir.
Thank you. Now we'll be going to a brief presentation by Professor Pillai on corrosives and heavy metals here, because this is some of the things which are seen, but we may not be knowing much about it. And with their experience, we would like to present the features in this condition.
Yes,
only
sir.
in heavy metals.
Can I start?
Only
sir?
heavy metals.
Can I start, sir?
Yes, sir.
Yes, I'll be sharing a screen. I hope the other person has stopped screen sharing.
Stop sharing, sir. PRC, sir, you have to stop sharing so that you can share.
I thought I had stopped sharing.
Not yet, sir. Not yet.
It shows only resume sharing and pass. So I have passed it.
Pillai sir, can you try, sir? Okay, sir. I can start my
Sir, you have to
share.
stop it. You have to stop it.
Can you see it, sir?
Yes,
Yes,
sir.
sir.
Yes. So I'll briefly talk about only two metals because time is short. Corrosives, I think we can dispense for the time being. If time permits, yes, I can speak on that also. As far as arsenic is concerned, with regard to, I think most metals, this is true. Many doctors feel that heavy metals are not very commonly encountered. Our experience here in the PCC is different. We routinely do heavy metal testing on samples. And we find that in quite a few cases, heavy metals like arsenic, lead, mercury, iron, etc. Are quite abnormal. I'm presenting one case of arsenic, which will show you that the notorious reputation that it has got has not gone away at all. This case involved a 37-year-old male IT professional who was working in Bangalore. On April 15, 2019, he came home, which happens to be in Kerala, and he was having his dinner and immediately developed nausea, vomiting, and loose stools. He was admitted to a local hospital, managed conservatively, became relatively well for the next 1 month. But then again, May 15, 2019, he had a similar episode, this time after he just finished his dinner, and he was again taken to hospital, but the symptoms took longer to resolve on this particular occasion. He also noticed this time around that he was developing numbness of both hands. He was discharged after 2 weeks in the hospital, but over the course of the next 1 month, he continued to have numbness and tingling of both hands and feet. By July 2019, he developed burning sensation of his feet also, and he found it difficult to walk. He also began to notice some skin changes in his palms and soles, and finally he stopped working and was staying at home because of all these problems. He developed loss of appetite. He was having weight loss, became uncharacteristically fatigued all the time, and virtually became bedbound. He was readmitted by the end of July. This is one image of his hand, taken by himself only, this snap, to show the characteristic kind of lesions that he was seeing in his palms and soles. This is nothing but hyperkeratosis. You can see the extent of scaling of the superficial layers of the skin of the palms and soles. And it is a classical kind of case of arsenic poisoning, which was missed by the doctors. In fact, they undertook a lot of investigations where he was admitted, on both occasions that I mentioned just now. A lot of investigations were done, almost none in toxicology, as you can see here. Even very esoteric kinds of investigations were done to find out whether he's having some problem that is not normally seen. But it is unfortunate that nobody thought of toxicology. And a picture like this, which I showed, this hyperkeratosis of palms and soles, so characteristic actually of chronic arsenic poisoning. And as you can see, the whole list of investigations, almost everything that you can think of was done, but nothing with regard to toxicology screening. And finally, when he was brought to Amrita, we suggested immediately heavy metal screening, first in the urine, which showed elevated arsenic level, and then we confirmed this in the whole blood by ICP-MS, which I spoke about earlier, that is there in the QSAT, Advanced Instrumentation Unit, which stands for Inductively Coupled Plasma Mass Spectrometry. It's supposed to be the gold standard for heavy metal analysis today. It is not atomic emission absorption spectroscopy anymore. The observed value was pretty high, 63.36 microgram per liter, whereas the reference value, the maximum range, should go up only up to 12. So it was a clear-cut case of arsenic poisoning. And we found from the history that he gave that the culprit was most probably his own wife, who was planning to marry somebody else. And she wanted to, terminate this marriage. This man was not willing to divorce her, and that is why she resorted to this. As to how she got hold of the arsenic, I'm not very sure, but on raiding the house where he was staying in Bangalore, the police did recover a small packet of white powder that was tested at the Forensic Science Laboratory in Bangalore itself and revealed to be arsenic trioxide, what we call white arsenic. And that was, of course, has become a big, medical legal case. And the case is progressing. I'm not very sure about the latest, kinds of developments, but the patient himself was subjected to chelation therapy and he became all right. I'll show you a figure later on as to how much recovery has happened with regard to his problems of his palms and soles. So arsenic, certainly commonest source of acute heavy metal poisoning, second only to lead in chronic poisoning. It's not really a heavy metal. It's actually an element with metallic properties. So you call it a metalloid. And there are a number of derivatives which are widely used, including arsenic trioxide, which was involved in this case, which is called white arsenic. You also have arsenic disulfide, red realgar, trisulfide, yellow orpiment, arsenite, which is Shields green, and acetoarsenite, which is Paris green. As you can see, almost all these are very colorful, kinds of substances. And arsenic has widespread industrial use. It's also used as an insecticide, wood preservative, pigment because of the variety of colors of its salts, and sometimes also used for getting rid of unwanted hair as a depilatory. It's used for various other purposes also. And please remember, like most heavy metals, arsenic is widely present in the environment, including soil, water, and food. You also have to remember about organic arsenicals, and the fatal dose of inorganic arsenic like arsenic trioxide is pretty low if it is acute poisoning. And arsenic, like many metals, can be absorbed through all portals, and it is some kind of a toxin that is very difficult to get rid of once it gets into the body, because it gets sequestered in certain tissues and also bones. The classical feature of acute arsenic poisoning is that of cholera, where you have a rice water diarrhea. There can also be garlic odor in the breath associated with these. There can be abdominal pain, vomiting, hair loss, the so-called Mees lines. I've shown you an image here, the whitish, kinds of bands across the fingernails. Very rarely seen in the toenails also, but mostly in the fingernails. There can also be other, problems relating to so many other organ systems. It's a multi-organ, kind of poison like most heavy metals. And the dermal manifestations are very characteristic. You can get melanosis in the areas mentioned here, hyperkeratosis of the palms and soles, almost pathognomonic. And then you have a kind of raindrop, pattern of pigmentation on the skin, especially of the trunk, as you can see here. Then the development of cancers, beginning with Bowen's disease, and so many other kinds of organs which are involved, giving rise to, again, multi-system manifestations. But diagnosis, you can go for the routine investigations like CBC, LFT, RFT, and all that, which can show abnormalities. And since it is radio-opaque, you can try radiography also, especially in acute poisoning. And you can also do nerve conduction studies, because often there is weakness. But the toxicological analysis is fairly simple. You go for, first of all, urine, 24-hour excretion. And once that is confirmed, you go to blood arsenic levels, which are confirmatory. Hair analysis is also there, but we don't do it. That is mainly meant for forensic purposes, not really required for clinical purposes. We do routinely blood arsenic level. Treatment, yes, aside from supportive measures, there are some chelating agents which are effective. One is BAL, which is also called dimercaprol. It actually stands for British anti-leukocyte, but the correct name is dimercaprol. And unfortunately, it is a very painful kind of administration of dimercaprol, which has to be given every 4 hours parenterally until the urine levels dip at least below 50 milligram over a period of 24 hours. Of late, a new kind of chelating agent has been introduced even in India, though it's really difficult to get hold of, and that's dimercaptosuccinic acid, or DMSA, and its cousin, that is dimercaptopropane sulfonic acid, which is even more difficult to get in India. DMSA can be obtained, however, online, and we have tried that in 1 or 2 cases. It's pretty expensive. The advantage of DMSA over BL is no doubt ease of administration, because DMSA can be given orally, and it is not a very painful procedure. It also has less toxic effects, less side effects. So that is all as far as I'm concerned on arsenic poisoning. I could have gone on to mercury also, but I think time is short. There are so many other speakers who are waiting. So I think we can go on to their talks. This is to show the same patient who has improved dramatically with the 2 rounds of chelation. We used actually a combination of DMSA in this particular case, as well as penicillamine, which is not really meant for arsenic, but can be helpful. Penicillamine is actually more helpful in copper. It's also called cuprimine. So that's all from my side. And please, I request all the pediatricians to be aware of heavy metal toxicity. It is very much, present. And in children, more than arsenic, we should be concerned about lead. Lead is supposed to be public enemy number 1 today, as far as WHO is concerned, with regard to chronic poisoning. And lead has got devastating effects in children. But I think that is a different, kind of session that we can take it up. This is beyond the scope of this particular session. Even mercury, I think I will not be able to take because of shortage of time. I hand over, the stage to the other speakers via Professor Dr. Thangavelu. Thank you.
So can you stop sharing your screen? Thank you so much, Professor Pillai, for that eye-opening, or should I say the mind-opening case scenario. Because as they say, what the mind doesn't know, the eyes don't see. So this is what we have to be really sensitized about. What are all the things one should keep in the diagnosis? It is not just only the straight jacket thinking. So we should really broaden our thinking in many times. Can you see your, yeah. I'll go back to my slides. Okay. Are you able to see?
Yes, sir. Yes, sir.
Yes, sir.
Are you able to see the screen, sir? Full slideshow.
Are you able to see? I'm not able to see clearly.
Yes, you're able to see.
Is it moving?
Slide. Yeah, now it is seen, sir.
Yeah. Dr. Rajkumar, the next case is yours. There are 2 children who were brought with convulsions, and the mother also was admitted with similar features. And on examination, they showed muscle twitching, excessive salivation, constricted pupils, bradycardia, and frothing in the mouth. But there is no history of ingestion, and there is no smell also in the gastric aspirate when he suspected some type of particular poison. Is it organophosphorus compound? Is it a possibility? How to confirm and manage? Because the toxicrome was suggestive of that. Dr. Rajkumar.
Thank you, sir. This is children are managed in a different hospital, but the features are very typical of organophosphorus, fits into the toxicrome. But there is no history of ingestion. In such cases, we have to go for an investigations to confirm the diagnosis after stabilizing the ABC. And normally for OPC, the diagnosis is straightforward. There will be either a smell or a history. So we don't do the levels because the turnaround time and the cost. But in this patient, definitely the cholinesterase level will be useful. And again, here both red cell cholinesterase level is more specific but not easily available. But the plasma cholinesterase, pseudocholinesterase could be done. And if it confirms the diagnosis, then we have it. And anyhow, after stabilizing the ABC, we need to go for the standard management. OPC is one of the commonest poisoning. So the screen is not seen, sir. It's one of the commonest poison seen and one of the causes which can result in mortality. So management of ABC, prompt administration of atropine and pralidoxin, and securing the airway and taking care of the ventilation is very important. The respiratory failure could be due to many reasons. It could be because of significant CNS depression, because OPCs have all the features. No? It can have nicotinic effects, the muscarinic effects, and the CNS effects. It crosses the blood-brain barrier. Or it could be because of the neuromuscular acetylcholine causing respiratory muscle paralysis. It could be because of secretions or bronchoconstriction. So many of these children, if they are having severe poisoning, they will require intubation, and ventilatory support, because atropine is not going to reverse the nicotinic effects and the neuromuscular junction effects. And while intubating these children, we should avoid using drugs like succinylcholine, because it will prolong the action, because that is also metabolized by cholinesterase, which is inhibited by the organophosphorus. And atropine, it's a standard treatment, but there are two ways in which you can atropinize. One is use a standard dose, 0.05 milligram per kilo. The same dose you can keep repeating till atropinization happens. Or alternately, you can keep on doubling the dose so that you achieve atropinization faster every 5 minutes. And people have found that to be more effective, but ultimately it works. And practically, we need to have a higher strength of atropine. The standard atropine vial, 1 ml 0.6 milligram will not be enough, because they will require lots and lots of atropine. And the end point would be the dryness of secretions, because tachycardia and the pupillary changes can be caused by the sympathetic stimulation, which can happen because of hypoxia and other features. So in fact, tachycardia and mydriasis is not an indication to stop atropine, and atropine has to be titrated to the dryness of secretions. And subsequently, you can either go for, after atropinization, you can either go for a lower dose infusion, or you can use intermittent doses of atropine to get atropinization. And again, it is also important to get the actual poison or actual organophosphorus. So ask them, in case if it is known, you can ask them to get the product, or at least if they know the color and other things, you can ask them to buy the new one from the shop, so that we can exactly see the composition, whether it's carbamate or organophosphorus, because for carbamates, pralidoxime will not be needed, and it can even cause problems because it has a mild cholinesterase inhibition action. If it is organophosphorus, then definitely pralidoxime is indicated, because it can help in reversing it. And early administration, especially, depends on the compound. Especially if it is dimethyl compound, the aging happens very fast. Irreversible inhibition can happen very fast. So it has to be administered early, but it should not be given as a bolus. It should be given as an infusion at least over 30 minutes and then repeated. And sometimes when you give a lot of atropine to dryness, sometimes the atropine causes delirium because of the CNS effects. In such cases, you can use glycopyrrolate, because it will not cross the blood-brain barrier, and you can use it to titrate to dryness of secretions. And some children, if the heart rate doesn't improve with atropine, you can use epinephrine. And some drugs like phenytoin and aminophylline and things should be avoided. Aminoglycans should be avoided, because either it can inhibit the action of pralidoxime, or it can cause prolonged weakness in the case of aminoglycosides, respiratory muscle weakness. And even if they recover, the duration varies depending on the poison. The duration varies, and so once we know the product, it's better to either contact a poison center or go to the net, because each product, even the response to the therapy is variable. So it's better to know the exact component, even though the clinical features may be the same. Some of them, the duration will be short. Some of them, the symptoms will be delayed. And we have to be beware of intermediary syndrome, especially the diethyl ones. The onset may be late, and sometimes the intermediate syndrome may happen as late as 3rd or 4th day. So they may have proximal muscle weakness, sometimes even respiratory failure needing ventilation. And they may also have other human changes like absent tendon reflexes, and it may be prolonged for a week or even more than that. And they may require ventilatory support to cover for respiratory failure. And this is different from, there is another entity called as delayed neurotoxicity. Some of the organophosphorus components have it. It may even start after 1 week, and it may be extended for up to 3 or 4 weeks also. So even acute management, plus you need to observe them, monitor them, especially if you know the product, you will know how long to monitor them to look for late complications.
Thank you, Dr. Rajkumar. In this child, the smell was absent because of
I think here, yeah, I mean, what I came to know is like the mother had actually injected this as an intramuscular and it was not given.
Okay.
This
Okay.
thing.
She
So I
had
don't know
some
the exact
medical
sequence.
knowledge and she gave.
Yeah, yeah.
So it's a suicide pact, like the whole family, she tried to. Okay. Thank you. Thank you, Dr. Rajkumar. Are my slides seen? I'm not able to see due to some reason.
You have to move the slide, sir. You are seeing the white screen.
Plain white screen.
Yeah, plain white screen. You move the slide, sir.
Yeah.
Next slide, sir.
Yeah. Dr. Sharda, this is your case. The child came with 10 to 15 ml of petrol kept in the water bottle 45 minutes ago, and parents tried to induce vomiting with salt water. What are the steps in assessment and management? Dr. Sharda.
Yes, sir. Thank you, sir. Good evening, everyone. Nowadays, even petrol is not available, and because of the price increase and everything. But even then, people have started storing petrols in bottles. Every petrol bunk, you see a person carrying a 1 liter bottle, trying to store petrols. So it is easily accessible by children at home. It is easily available at children at home, and because of this PET bottle and the water bottle storage, they get confused. And kerosene, as mentioned by Dr. Srinivasan, it is the leader of toxic ingestion in children nowadays. Most common hydrocarbons which a child can encounter is kerosene, petrol, or paint thinners. And the primary insult is in the lungs. Whenever this kerosene and petrol are low viscous hydrocarbons, they tend to get evaporated very easily. And these vapors, they affect the lungs. They cause inflammation wherever they pass by, and they induce loss of surfactant, leading on to multiple levels of lung damage and ARDS very easily. Because of hypoxia, and these children will have other system involvement as well. And the vapors of petrol and hydrocarbons, they can cross the blood-brain barrier, causing encephalopathy very easily. So these children, initially they come with respiratory distress if they have got lung symptoms, then they progress onto encephalopathy. So our assessment should be always airway, breathing, circulation, disability, and exposure. And the treatment as such is based on the symptoms. Admit all the symptomatic kids. No stomach wash, no stomach wash, and no stomach wash. And in the particular case scenario, the parents, because of panic, many a times they try to induce vomiting, and after vomiting, they induce vomiting, they come to the hospitals or the emergency room. So the stomach wash by itself will increase the risk of aspiration. And many a times these children require respiratory support. Identify and treatment of hypoxia is the first step. And there is no role for antibiotics or steroids. Based on the level of inflammation or the presence or absence of ARDS, the degree of oxygen supplementation varies. And if the child comes encephalopathic, it is airway stabilization by intubation, and management with the ventilation is the norm. So the radiological changes, usually they may take up to 12 hours. So when a child reaches emergency department within 2 hours of ingestion or within 6 hours of ingestion, we tend to wait and then take the X-ray at 6 hours or 8 hours before discharging. Kindly keep them under observation. Please do not send them home saying that the child is looking normal, there is nothing wrong, because the kerosene tends to get vaporized, and it will continue, the inflammatory process will continue for a longer time. The second thing is many times when once they reach the emergency department, it is always better to remove all the cloths and give a thorough skin wash, so that there won't be any ongoing dermal absorption of these gases. Once they vomit, the cloth and everything is fully absorbed by this kerosene or petrol. So it is better to give a wash. Even if they have given wash at home, it is better to give a wash again at emergency department. And once the radiological changes happen, the clearance takes a longer period of time. So this is a very simplified way of managing the hydrocarbon exposure. If the airway is stable and breathing is normal, we have to observe in emergency department for 6 to 8 hours. If they are remaining asymptomatic at the 8 hours, we can plus or minus discharge the child. The child develops symptoms, like respiratory distress, we have to admit and continue the care in PICU. If this airway is unstable on arrival and the child has shock because of hypoxic myocardial dysfunction, we have to manage the shock accordingly. Most of them will develop cardiogenic shock. And we have to remember a fact, these children are very easily prone for arrhythmias. So here the caveat is treating with catecholamines. So take a call. If the child is hypotensive, the first line of treatment will be adrenaline. If the child is not hypotensive, try to avoid catecholamines and based on the shock, manage accordingly. If in case of arrhythmias, lidocaine will be the preferred this thing, because ventricular arrhythmias are most frequently seen in a hypoxic myocardium. If the child comes with seizures, follow the status epilepticus protocol. Benzodiazepines are the preferred this thing, because the hypoxic myocardium is will worsen with phenytoin. It is always safer to avoid phenytoin or phosphonatoin in children in general who have any toxicologic exposure, and in particular petrol and kerosene exposure.
Thank you, Dr. Sharda. The last case scenario in this session is to Dr. Sindhil. This is an 18-month-old child residing at Tirupur, which is the area for this kind of poison. Tirupur, Coimbatore, those areas, Erode. Ingested unknown quantity of cow dung colored powder, popularly known as sani powder in Tamil, which comes in different colors 3 hours ago. Child has got some retching and vomiting. Unlike the name, it is nothing to do with cow dung. It's only the color. Is it dangerous? What are the clinical manifestations and the management principles?
Very good evening, sir. Thanks for the opportunity to present in front of my Professor TVR. So the cow dung powder poison, it's a misnomer. The sani powder is a misnomer. It is just an artificial thing which is comes in a synthetic. So it is correctly called as synthetic cow dung powder poison or synthetic sani powder poison. It comes in 2 colors. It has a very long history, sir. Initially, it was containing a heavy metal, arsenic, as Dr. Pillai told. The arsenic was there in yellow color and copper was there in green color. Over a period of time, when this cost increase and the competition comes, they want to come in a reduced rate. So they change the heavy metal into dye. So now the yellow color contain aramine O and green color contain malachite green. So it is mainly used for coloring and coating, in especially in the festival time they used to do this, and it is more toxic when it is consumed in a higher concentration with a little dilution, just like putting one initial packet, entire packet in 100 ml or 50 ml of water or a glass of water, then they will have toxicity. So the lethal dose for a yellow aramine O is 50 milligram, and malachite green is 11 milligram per kg body weight. So the mainly we see the yellow. This is our patient. You can see the entire face, the mucosa, urine, and all body fluids will be colored yellow. And mainly it causes GI symptoms as well as CNS. CNS, it goes for toxic encephalopathy. We have witnessed starting from simple seizure, altered sensorium to posterior reversible encephalopathy we have seen, and they had a severe cerebral edema. And if it is green color, they go for mainly acute kidney injury, and they also go for toxic myocarditis and shock. Next slide, please, sir. So the complications are starting from simple cramps, spasm to death has been witnessed, and now understanding the pathophysiology, now the mortality has been reduced much, and the main management in this is decontamination, starting with activated charcoal. And if the patient is having a convulsion, please remember, any patient with a toxicology having a seizure, don't give phenytoin. It will not going to work. You can give a benzodiazepine subsequently if their sensorium is okay and airway is protected, then you no need to intubate. Otherwise, you have to intubate this patient, and you have to give phenobarbital if continuous seizures are going in. And another one important thing is, if the patient comes to you early and the patient is within an hour, you can do a decontamination and the early urine alkalization can be started. And this COVID period, we have witnessed more amount of sani powder. And this is mainly because the sani powder, this synthetic dye is weakly acidic. So, and it is mainly starting by urine alkalization with the soda bicarb. We can able to prevent the more unionized compound entering into the tissue causing the damage. So this is just like similar to iron trapping. So once you give this bicarbonate and starting urine alkalization, the patient improves very fast within 48 hours. Sir?
So I think we have covered all these things. So we're very happy to hear it from a person who has actually done some work and published on this. Thank you, Dr. Sendil. Interestingly, these compounds have been banned as early as 2007. But still,
yes,
they are quite
easily
available.
Heavy metal, sir. That is heavy metal component is banned, sir.
Okay. These colored components are not banned.
It is freely available, sir, now.
Okay, right. Thank you. Thank you, Dr. Sendil, for this information. Now I hand over to Dr. Thangavelu.
Thank you.
And thank all the participants. Thank you.
Can you stop screen? Okay. Sir.
Yeah, I will do that. I have passed it.
Yes, sir. Thank you all the viewers and faculty. I think probably we're extending our time. I'll try to finish up as early as possible. This is the second round of panel discussion. Same panelists. So we are going to cover, these are the panelists and these are topics we are going to cover. To begin with, I just want to share this information that pediatric emergency, in every pediatric emergency, presenting the alter sensorium, toxins ingestion is almost a third cause after injury, infection, and exogenous intoxication. Endogenous intoxication is a metabolic disorders. The difference between adult and children in poisoning is adults declare after poisoning. The child, they come in silence. They don't declare. They come in an emergency, which is up to us to identify this is caused by poisoning. Particularly, we can suspect poisoning when there is a vacuum in the history. For example, a child comes with fever, cough, ear discharge, seizures, and altered consciousness. Chronologically, we can see the sequences to make a diagnosis of probable CNS infection. But if the child comes, a well child suddenly comes with seizures and altered consciousness, think of poisoning. Similarly, a fever, cough, breathlessness may make a diagnosis of pneumonia. But if the child with sudden onset of breathlessness, again, think about poisoning. Of course, when there is nobody else to narrate the sequences, think about poisoning. So, in short, every pediatric emergency consider poisoning also an important cause, particularly when there are no clues. Over to Dr. Akila. This is a 5-year-old child brought to the alleged accidental consumption of ALA liquid, about 4 to 5 ml kept in the used water bottle 2 hours prior to the arrival in ER. Child is hemodynamically stable, erythematous oral cavity, system examination was normal. How are you going to manage this child?
Good evening, sir. And this child being hemodynamically stable, as we discussed earlier, detergents are the second most common poisoning in the child. We all know that detergents usually has alkalis, acids, and hydrocarbons. This particular child was hemodynamically stable with except for that erythematous oral cavity with burning pain. So we admitted her in her high dependency unit and observed. We kept her NPO and no stomach wash was given, managed with IV fluids. 4 to 6 hours later, she developed abdominal pain and vomiting, which was managed symptomatically. Chest X-ray taken after 8 hours was apparently normal. And she was started on oral liquids after 24 hours, which she tolerated, and semi-solids also tolerated. And she was discharged after 24 hours, but it was an against medical advice discharge because we asked the parents to observe for further 24 to 48 hours as we expect delayed complications like strictures, everything. Since in the early phase, we could not exactly know the severity of the lower esophageal and lower GI symptoms. So this first management sounds very simple, that she admitted discharge, but after a week, she was brought with complaints of vomiting and inability to swallow solids first, and gradually it progressed to liquids also, to the extent that she will have a bit sips of water or whatever liquids, then she will spill it out. She will have a cup nearby her to spill the liquids. So this was the severity of the things. So when the evaluation showed a severe esophageal stricture pertaining to all the symptoms which she presented, and as per the gastroenterologist opinion, she went periodical esophageal dilatation, but it was failed, and later she underwent a gastric pull-up surgery recently, maybe 2 to 3 weeks back. So this gives an idea that our timing and observation in certain poisoning is very, very important pertaining to the poisoning. Next slide, sir. So in case this child being stable at the presentation, we managed symptomatically, and then after 2 weeks she progressed, and that management was a complete different thing. In case if the child is unstable at the presentation itself, again we are going to stabilize the airway breathing circulation, and in this case you always anticipate a difficult airway and hemodynamically unstable child. So you be prepared with an expert like ENT surgeons, and observation is must for this detergent or any hydrocarbon or acid alkali poisoning. At least for 48 to 72 hours, we have to wait to know the symptoms, whether it is evolving or not. And as I said earlier, we can underestimate the severity of the internal injury in the early phase. So the endoscopy is very controversial. The duration and timing of endoscopy is controversial. Maybe from 12 to 72 hours, they are saying. It depends upon the severity of the cases. And if at all you want to put an NG tube, usually please avoid it. And if at all you want to put, you put with an expert. And other investigations are routine, as we know, to find out the airway compromise, X-ray, neck, AP and lateral, chest X-rays and blood investigations. Mainly the treatment will be symptomatic, like antacids and anti-reflux, and antibiotics, if at all, if you, there is going to be necrosis with superadded infection, if you suspect, antibiotics. Otherwise, antibiotics have a less role in this detergent poisoning.
Thank you, Gla. What I understand is when the child comes in acute stage, main distinction is the airway management. If the child has any hoarseness of voice, a stridor, as the speaker already mentioned, we need an expert person, an anesthetist or intensivist or ENT surgeon to intubate the child so that the airway securing may be difficult later. And if there's a pediatric gastroenterologist with a very good experience in endoscopy is available, it's say that in first 24 to 30 hours, we can do an endoscopy very carefully. This will help us to assess the extent of damage. For example, the whole esophagus stomach is extended. Then we have to plan for an alternative way of feeding the child, like a TPN or some other measures. So generally, we think that we don't have corrosives at home. These are all these things are corrosives. Most of the thing which is used in the toilet cleaning agents. If you look at this, it is kept in the Sprite bottle. Toilet cleaning acid is kept in the Sprite bottle. Child took it, and then it came with the corrosive injection. Thank you, Akila, for highlighting on the topic. Now we move on to the second topic. This is a 4-year-old child present with bilateral upward gaze, jerky movements, opisthorontic posture, slurred speech, and features were suggestive of extrapyramidal symptoms. In fact, child was normal till afternoon. After afternoon, child developed the symptoms, acute dramatic onset. So vital signs were stable. It was afebrile. When we inquired the child, parents were not able to clear. Initially, when we entered the ER, they deny any drug injection by the child. So now I request Debasis to how to proceed with this child. What other drugs are likely to cause this similar illness?
Yes, sir. Yes, sir. This child came to us. So because this child, the symptoms was very sudden, so we strongly suspected poisoning, especially when these extrapyramidal symptoms were there. So we have taken care ABCD, and we have done stomach was and activated charcoal was given, and we sent the relevant lab test, and which was also within normal limit. And then we further evaluated the family history, and then we found that the elder sibling was suffering from autistic disorder and ADHD. And recently for the ADHD, they have started on second generation antipsychotic medications. And then we told the parents to bring the tablet, and it was Risperidone. So anyhow, because of this, we strongly suspected that this child might have taken the elder sibling tablet, which is risperidone. So that's why I thought it could be a extrapyramidal complication due to risperidone.
How do you manage, Professor Devas? How did you manage the child?
So this child, we have taken care ABCD and
hello.
And that extra elder sibling taking risperidone, we given diphenhydramine, that is Benadryl. That is, we are given 5 mg per kg in 4 divided dose. So Benadryl orally we are given 5 ml of Benadryl has 12.5 mg. So we calculated a dose and we gave the child every 4th hourly calculated dose of diphenhydramine, and within 12 hours the symptoms subsided. And then after that, there was no extrapyramidal syndrome after that, and we observed the child for 48 hours. Though twice a day we gave Benadryl, and we discharged home with 2 more doses of diphenhydramine, and next 24 hours, and child was all right at home.
What are the other side effects of risperidones? What we should expect?
Yeah, risperidone actually we can. This child had agitations. And then this child, actually, these are the drugs commonly given for the adolescent and child for mania, and then bipolar disorder and psychiatric problems. So the other children, they accidentally take this risperidone.
Hello.
Extrapyramidal symptoms and CNS depressions. Sometimes you have to be extremely careful because they can have tachycardia and QT prolongations. And because of the QT prolongation, they are prone for arrhythmias.
Arrhythmia also, that's a very dangerous complication. Thank you, sir. So what we do is, from here in ICH, we used to give benzodiazepines, either diazepam or lorazepam can be given, particularly when they come with the dystonic reactions. Parents are very anxious. So the diazepam may take some time to control it. So careful IV diazepam or lorazepam, which is given for a convulsion dosage. 1 dose will completely relieve the symptom. Then we can follow with the dicyclomine. These are the other drugs, metoclopropamide, which was used earlier for vomiting. Even a higher dose of domperidone, because some companies are coming with 1 milligram per ml, 1 ml, and 10 milligram per 1 ml. So if you mistakenly give a higher dosage, that can lead to external symptoms. Triflupromazine is generally chlorpromazine, haloperidol. When they are used in specific situations, they also can lead to external symptoms. Thank you, sir. Thank you, Professor Debasis, for nicely explaining this child.
Thank you, sir. Thank you.
The next case, over to Professor Jayakrishnan. This is a good 11th standard child. He got a failed mark in low mark in mathematics. So what we thought was he consumed rat killer. She consumed paste on the first day, second dose paste on second day morning, and third day she took cake. She got admitted on third day with hepatic failure and icterus, no bleeding tendency. But see, the transaminases are very high. Creatinine was normal. Platelet count started lowering. So started going down. How are you going to manage the child, Professor Jayakrishnan?
Okay, sir. Thank you. So what we encounter generally are 3 kinds of rat poisons. One is the yellow phosphorus, which is the most dangerous one. What is shown here, ratol is one trade name. The other one is a zinc phosphide. Usually that comes as a black powder here. It can be like tablets also. And the third one is the super warfarin, which we are not discussing here now, because that is much less dangerous compared to the other 2. And what this girl has ingested is a combination of both, possibly zinc phosphide and yellow phosphorus. So this particular paste contains yellow phosphorus, which is dangerous. It contains about 3% yellow phosphorus. In fact, the fatal lethal dose is 1 milligram per kilogram, which is we have seen children actually using this, mistaking this for toothpaste and brushing their teeth and developing liver failure and dying. Like what we described for iron poisoning earlier, many of these children have about 3 phases of toxicity. Like the first phase within the first 24 hours, when they have general gastrointestinal symptoms like abdominal pain and vomiting. Then that is followed by a relatively asymptomatic period. And then again, the third phase, which can, the onset can be variable, and it can be days to weeks. Sometimes we have seen even children developing hepatic failure after 3 to 4 weeks after the ingestion. So these are the 3 phases. So what is important is actually the treatment that is available is only supportive. And you have to make sure that electrolyte imbalance are treated properly. For zinc phosphide, we need to look for hypomagnesemia particularly, but then hyperkalemia and hypocalcemia are also seen with both yellow phosphorus as well as zinc phosphide. For this particular child who has developed frank hepatotoxicity, hepatic failure, we can try all the supportive measures, and then the child is not improving. We may have to treat this like any other child having liver failure. And then many experts now recommend therapeutic plasma exchange as an option for these children when they actually develop features of systemic involvement. But then many of them may end up in liver transplantation also. And mainly this yellow phosphorus as well as zinc phosphide affect the cardiac dysfunction, cause cardiac arrhythmias as well as liver dysfunction. So initially, if it is a very large quantity injection like what this girl had, probably on the first day or two itself, they can develop cardiac toxicity in the form of arrhythmias like both atrial and ventricular arrhythmias, prolongation of QT interval, and all dangerous arrhythmias. And then in the second phase, they develop multi-organ failure, especially the liver. So mainly it's the heart and the liver that's involved. And we have seen many cases developing liver failure many weeks after the injection. So after an apparent asymptomatic period. So it's very important that you continue monitoring these children for development of liver failure, even if they are totally asymptomatic during the first few weeks. And
how effective is NSL system?
Yes.
NSL
there are many papers find N-acetylcysteine to be effective in preventing development of multi-organ failure later. But then no definite conclusions have been arrived at. So, but we routinely give N-acetylcysteine for all children coming with the history of ingestion of zinc phosphate or yellow phosphorus for all children.
Thank you, sir. I also agree with you that is one of the poison which causes death in very high rate of death. I think you also would have faced a similar situation, mortality. Almost half the kids, they die. This is one of the unpublished papers say that out of their experience, as you said, plasma exchange seems to be a very useful one. They managed some 24 patients, adult and children. Out of the 20 patients improved without the need for liver transplant. They improved with the plasma exchange itself. And 2 patients went in for urgent liver transplant, 2 expired. So it's a good number of, out of 24, 20 could be saved by plasma exchange. That is really good news. Because once that, then after seeing this, we realize that if we happen to meet a child with liver failure, then probably we have to refer to a center where plasmapheresis can be done and can be saved without going into liver transplant. Thinking about any child presenting liver failure, we should also consider the possibility of paracetamol, sodium alparate, and other things also can lead to liver failure apart from these toxins. Thank you, Professor Jaykrishnan.
Thank you, sir.
Yes, sir. Any other comments?
Sir, Sendil, sir.
Yes, Sendil.
Sir, regarding this Retol poisoning, as you rightly pointed out, it is mainly seen in our place and Delta districts, sir.
Okay.
We used to get patients from Kumbakonam, Nagapattanam, Nagarkoil and all, sir. We do MARS in our center. Even the plasmapheresis has been done, and if they are not improving, even we can do a MARS little earlier, so that definitely the mortality is reduced, sir.
It's a bridge therapy before liver transplant, is it, sir?
So no need for a liver transplant at all, sir. It reverses on its own, sir.
Thank you, sir. Thank you, Sendil, for the new information. Thank you. Next case discussion for Dr. Lakshmi. This is 2 kids were brought in a drowsy state. Heart rate was 50, pulses well felt. Their afebrile pupils were normal, blood sugar was 50 milligram. Manage an ER of the dextrose. This is the ECG showing. So we have a child, 2 kids with bradycardia and hypoglycemia. Now handing over these children to Dr. Lakshmi, is the ER physician. Over to Dr. Lakshmi.
Apparently well child with no preceding symptoms and signs suggesting pointing towards any disease. So definitely I will consider drug poisoning only. As per PALS also treatable conditions of bradycardia 5 H's and T's. So toxins are very important. And all the more we know that beta blockers nowadays they are prescribed for elderly people for coronary artery tachyarrhythmias, anxiety, migraine, etc. So definitely in this setting of a young child with bradycardia and hypotension with any rhythm disturbance, my first differential diagnosis will be that beta blocker toxicity in this case, and of course calcium channel toxicity also. And with the setting of hypoglycemia, definitely we should think of oral hypoglycemic agents toxicity, and then beta blockers, quinine, insulin, ethanol, salicylate, etc. So this combination of bradycardia with hypoglycemia. So first my diagnosis will be to consider beta blocker, then oral hypoglycemic agents and calcium channel blockers. So briefly to discuss about this oral hypoglycemics, sulfonylurea, they can cause profound hypoglycemia. The onset can be as early as 6 hours, but can be delayed up to 16 to 18 hours. And it causes immense insulin release because of calcium channel activity. And we should not be giving repeated IV glucose, because repeated glucose can cause further insulin release and rebound hypoglycemia. So the antidote here would be to consider octreotide. And then specifically for metformin associated, then it is hemodialysis. And considering this beta blockers, most toxic is propranolol, which is highly lipophilic, and because of lipophilicity, it diffuses into the CNS and causes altered mental status, seizures, and coma. And least toxic is water soluble atenolol, and we know because of intense activity on chronotropy and inotropy, it causes bradycardia and hypotension and heart block and widening of QRS, ventricular dysarrhythmias, and hypoglycemia because of impairment of glycogenolysis, and bronchospasm because in airway diseases it can happen because of the inhibition of beta 2 activity on the airways. And here the treatment would be glucagon IV, which is a somatostatin analog, calcium vasopressors, soda bicarbonate if the QRS widening is more than 100 milliseconds, and benzodiazepine for seizures. And we have to observe child for longer period, more than 48 to 72 hours for lipophilic agents and sustained release preparations. Coming to calcium channel blockers, there are two types of calcium channel blockers, that is dihydropyridine group and non-dihydropyridine groups. Non-dihydropyridine groups are verapamil and diltiazem, dihydro or amlodipine and nifedipine. This verapamil and diltiazem, they have effect both on heart and blood vessels, so they can cause bradycardia, hypotension, and rhythm disturbances. The one thing is that in calcium channel blocker, we can get both bradycardia and tachycardia. Verapamil and diltiazem will cause bradycardia and hypotension, and amlodipine and nifedipine, they have effect only on blood vessels, so that causes diminished SVR and reflex tachycardia. So bradycardia and tachycardia both can happen. And other common feature is hyperglycemia because of inhibition in insulin release. Treatment here would be gastric decontamination, IV calcium, and high dose insulin therapy, because that will for toxic myocardium, it will be giving more of carbohydrate for myocytes, and judicious IV fluids, and vasopressors, cardiac pacing, and lipid emulsion therapy.
Thank you, Dr. Lakshmi. So understand that a child comes with poisoning and bradycardia with hypoglycemia, I will consider beta blocker as a possibility. The same in another child comes with bradycardia and hyperglycemia, I will think about calcium channel blocker. At the same time, we'll also think about the plant alkaloids like oleander and others. Thank you, Lakshmi. Thank you, Lakshmi, for an elaborate discussion about this. Now over to Dr. Punitha. This is a 4-year-old child who was well 4 hours ago, and he was playing with his brother in the garden, now brought with seizures. He's afebrile, seizure got controlled medication. What do you think the cause of the seizures? The child was well child playing in the garden and coming with seizures.
So as there is no previous history of any illness, we are suspecting poison in this case, sir. So I am, as the attendants got this bottle of gamma benzene hexachloride, I am thinking it as organochlorine compound poisoning. It is a common insecticide used in agricultural fields. The common manifestations here are dermatitis, seizures, ataxia, and confusion. Coming to gamma benzene hexachloride, it acts on the gamma aminobutyric acid antagonist and block different voltage gated ion channels in the central nervous system. This leads to release of excitatory neurotransmitters, and it causes agitation and seizures. This gamma benzene hexachloride is lipophilic, and it is retained in the lipid-rich tissues. So if you examine the blood, the levels may be underestimate when compared to their status. Fatty food should be avoided because it enhances the absorption of the toxin. Rarely they can present as rhabdomyolysis, pancreatitis, and DIC. It can also present as acute hepatorenal failure. In our office practice, we are using it for scabies and pediculosis. So if there is any miscommunication in prescribing the drug for topical application, the mother can give it orally, and this can lead to some poison. So we have to communicate the mother and explain about the mode of administration if you are giving for scabies or pediculosis. The treatment for this is symptomatic management for seizures using benzodiazepines, and activated charcoal can be used. It enhances fecal elimination. Dopamine can be used for hypotension. Cholestyramine, that bile acid sequestrant drug, can be used. It reduces the reabsorption and retain the bound agent in the gastrointestinal tract and help in fecal elimination. There will be potential exacerbation of symptoms if we treat with atropine or pralidoxine. These drugs should be avoided. If liver abnormality is suspected, we can use N-acetylcysteine. The other
Dr. Punitha, there are other compounds which can also result in seizures. For example,
Yes, sir.
commonly which is available as chalk or Lakshman Rekha. Can you just elaborate on those poisons which can cause the symptoms?
Yes, sir. Coming to Lakshman Rekha, it belongs to pyrethroid groups. There are two types in the pyrethroids. One is with cyano group. The type 2 is with type 1 is without cyano group, and type 2 is with the cyano group. The cyano group compound is more toxic to humans. It is it's made up of delta methrin or cypermethrin and is used in the form of chalk sticks, locally called as Lakshman Rekha. It is available in powder and liquid form also to ward off the kitchen insects. It causes type 1 hypersensitivity reaction like anaphylaxis or irritant action to the exposed mouth, lips, eyes, or skin. ECG may demonstrate ST and T changes, sinus tachycardia, and ventricular premature beats. If ingested in large doses, it may produce neurotoxicity like tremor, fasciculation, convulsion, coma, and even respiratory failure. It acts by prolonging the activation of neuronal voltage-dependent sodium channels and causes prolonged depolarization. Synthetic pyrethroids can be combined with organophosphorus compound, and this will lead to increased mortality and morbidity. They may present us with increased salivation, upper gastrointestinal bleeding, and rarely renal failure. Coming to the treatment, there is no specific antidote. Airway, breathing, and circulation management, followed by stomach wash, can be used if the history of intake is within 1 hour. Activated charcoal can be used. To control seizures, we are using benzodiazepine. In case of increased salivation, we can use atropine also.
Thank you, Dr. Punitha,
Thank you,
for explaining in a very nice way. This is a simple algorithm. If you think the child has come with convulsions, we strongly think in terms of toxin injections. This simple algorithm will be helpful. Think of household substance or medicines. So how do you decide? It's depending on availability only. If the parents say there are no medicines available, these are the common household substances available. You think about those things: camphor, neem oil, gamexin, mosquito repellent. All this can lead to convulsions. So all depending on the availability, we make a diagnosis only by the environmental clues. If you think the medicine is responsible for convulsions, check the glucose, capillary glucose, glucometer, check the glucose. If the child has got hypoglycemia on convulsions, it may be oral hypoglycemia agent or beta blockers. If the child has got high glucose, it's secondary to isoniazid and theophylline. These two can cause hyperglycemia on convulsions. If the glucose levels are normal, it is tricyclic antidepressant. So this will be really helpful to arrive at a diagnosis within a short period because we don't have facilities to check all the levels. If the child has got high ananga metabolic acidosis, hyperglycemia, and convulsions, very strong possibility that you are dealing with isoniazid. The child has got hypoglycemia, tachycardia, child has got tachycardia and dilated pupil, ventricular arrhythmia, think about tricyclic antidepressants. So all these clinical clues will help us to come to the narrow down the possibilities. Rajkumar, this following family quarrel, mother gave around few early seeds to 3-year-old daughter and she also consumed it.
and now admitted in adult ICU. Child is admitted in PICU. Child is conscious and admission to PICU after vomiting. Heart rate is 56, BP 80/50, pulse are well felt, A febrile, pupils are normal. How will you proceed managing this child, Professor Rajkumar?
Sometimes
the ECG of the child.
The ECG of the child shows sinus bradycardia. So it is one of the common poison which is used in South India and Sri Lanka. It's not so common in the rest of India. And in this particular family, the mother was admitted in adult ICU, child in the pediatric ICU. Father was arrested because of the quarrel. He had abused the mother. So it a very social problem was there. And as you see, this is the yellow oleander. The seed is the one. All the parts are poisonous, but seed is the most poisonous. And many Tamil movies you have seen, the heroine usually consumes this early seeds to commit suicide. And red and white oleander is also used. Basically, they all are cardiac glycosides. Like foxglove is the one which is the source of digoxin. They all act by inhibiting the sodium potassium ATPase. So it increases the contractility by increasing the calcium. But on the other hand, it also has other problems. So one is it can cause hyperkalemia because potassium is not allowed to enter inside. Plus, it can act on the AV node to cause bradycardia. And it can cause other arrhythmias like second-degree heart block, either type 1 or type 2 Vecchibax, or it can even cause complete heart block and QT changes. And the approach would be, the first thing would be to do a good history examination, baseline investigations, including ECG, because rhythm changes and QT changes are important, and electrolytes, and stabilize the patient and see the risk factors. So I think there are studies which have been done in India from CMC Vellore, Viluppuram Government Medical College, where they have found that if the history is that they have consumed more than 3 seeds, especially if the seeds have been crushed and taken, and they have reached the hospital after 2 hours, so you don't have the opportunity to do an early gastric decontamination is not possible. Or if they already come with myocardial depressant clinical features, like either shock or significant, I mean, this bradycardia for adults, so pediatrics we can modify it accordingly. And the ECG changes showing either heart block or irregular heart rate. If these factors are present, not present, still we need to monitor them for 24 hours, because sometimes it could be slightly delayed, and then still it is better to observe for another 24 hours before you discharge. But if any of these things are present, then ABC, gastric decontamination, if they are presented early, and the initial supportive measures could be, because of the bradycardia heart block, you can try atropine, you can try drugs like isoprenaline, or orsiprenaline can be given orally, or isoprenaline as an IV infusion. And some children may respond. If there is a good response, then you can continue to monitor. Otherwise, it is important that we transfer the patient to a tertiary center. So the main message is, these patients, sometimes they will deteriorate very fast, resulting in mortality. And the only way, only intervention which will be helpful for them is insertion of a temporary pacemaker and to normalize the heart rate. So you should refer to a place where a temporary pacemaker is available. Of course, the other antidote theoretically is the digibind or the digoxin FAB, but that is very expensive, and single dose is more than 3-4 lakhs. It is not available in India. It has to be imported. You will not get it quickly. So it is more of theoretical. So mainly it is drugs like atropine, isoprenaline, and temporary pacemaker. And maybe there may be a role for, because some children in tertiary centers have died in spite of putting a temporary pacemaker, because it can also cause shock by other mechanisms, vasodilation and myocardial. That is very rare. So those patients, maybe there is a role for cardiac ECMO, because the other poison like aluminum phosphate, which is not so commonly seen in South India, in North India it is common. And previously the mortality was very high, but after they initiated, I think from Ludhiana, they have done a lot of cardiac ECMO, and they have survived. So maybe there may be a role, but we couldn't find any report so far. The main message is early referral to a place where temporary pacemaker is available. So that is the main thing about oleander. Coming to other things like I think we already seen beta blocker, calcium channel blocker, which can also cause problems with the heart rate. But usually those children will have hypoglycemia in the case of beta blocker. And again, other things which can cause bradycardia could be OPC, where you can have all the classical features of dumbbells, seizures, twitching, and pupillary changes, meiosis. Even sedative drugs, narcotics will cause pinpoint pupil. But in addition to that, there are significant CNS depression, shallow breathing, respiratory failure. That will help. And again, the electrolyte changes, the oleander or digoxin, will also cause hyperkalemia because it blocks the sodium potassium ATPase. They will have hyperkalemia, and management of hyperkalemia is also important in these patients. Sometimes for digoxin, magnesium is also useful. So you can give magnesium, and many times digoxin toxicity may happen in patients who have a renal dysfunction. So those patients, there may be a role for dialysis. Otherwise, routinely dialysis is not useful for digoxin. Magnesium can be tried, and it is mainly controlling the heart rate. The other cardiac myocardial depressant is Uduvan-Thalai poisoning. I have not managed the patient, but it is more common in southern districts of Tamil Nadu. It is much more potent than oleander, and it can cause higher mortality, and the symptoms can be even delayed. Even the mortality can be delayed by a few days. It presents with initial GI symptoms. Here, the arrhythmia changes can be there, but that is less important. The temporary pacemaker, people have tried, but they have not found much of a difference. It is less important in causing mortality, but it causes other problems like it causes something like a distal renal tubular acidosis, like normal anion gap metabolic acidosis. It causes hypokalemia, whereas oleander and other things can cause hyperkalemia. This one causes hypokalemia, just like a renal tubular acidosis and hyperchloremia. There are reports of ARDS, shock due to vasodilation and acute kidney injury. And all these things needs ventilatory support and fluid, inotropes, and renal replacement therapy. There are reports of N-acetylcysteine being tried, but again, because of small numbers, there is no clear conclusion whether it is beneficial. So if you have a patient, monitoring the rhythm, again, temporary pacing if it's required, supportive management of ABC and bicarbonate for metabolic acidosis. You can give N-acetylcysteine and C.
Thank you, Professor Rajkumar. You stress the importance of repeated monitoring. I just recollect an incident happened when I was working in ICU. A child, adolescent girl was brought with altersensorium. There was some bradycardia was also there. We thought it is because of ICP. Then we called routine management as like an acute encephalopathy, called the neurologist. Lima Paulin came in the afternoon, professor of neurology now. She called me and said she identified twitching of the muscles, very subtle finding. Then she said twitching of the muscle. Then we retrospectively thought twitching, bradycardia, and excessive secretions. Then we thought about organophosphates. When we sat with the parents and asked about their colleagues and students who went along with them in the field, she took water from a bottle kept in the field side, which contains OPC. See how nicely the differential diagnosis changed from a very bad encephalopathy to OPC poisoning. With the actually antidote, she completely recovered. So that shows, as Professor Rajkumar said, repeated clinical monitoring will definitely help, irrespective of all the other investigations. Thank you, Professor Rajkumar. We will move on to the next problem. Nowadays, that Sharda, nowadays it's becoming very common to see button battery injection, at least 2 per month. Can you tell us how we can manage and what are the cases you encountered?
I agree with you, sir. That too, post-COVID, when all the kids have nowhere else to go, and children started taking whatever is available at home, be it button battery or 3A battery. We received cases of ingestion of 3A batteries also. So it was shocking to see what all kids can ingest other than the food. So then button battery, as such, the ingestion is very easily manageable, provided it has crossed the esophagus or the narrowest parts of the gut. So this is this previous slide. We see the passage. It takes the time it takes to traverse the gut once it enters the stomach. So beyond stomach, usually it is not retrievable very easily, because when it passes through the pylorus very easily whenever you put an endoscope. So beyond stomach, usually they do not retrieve, but if the child reaches the ER within 2 hours, or if the child X-ray showing esophageal impaction and the negative side of the battery, usually in contact with the esophagus or the body tissue, it is always better to remove. If the child has ingested button battery along with magnet, again it's an emergency endoscopic removal. Recently papers have started coming where they are advising to give 10 ml of honey every 10 minutes before the child reaches the emergency room. Honey is not generally contraindicated less than 1 year, and if the ingestion is more than 12 years, because it is assumed that it has crosses the esophagus, or there is features of esophageal perforation. And up to 10 doses, up to 6 doses, you can give honey, because they say the alkali nature of the honey neutralizes the corrosive button battery complications. But once the child reaches the emergency department, it is always better to take an X-ray and then see whether the foreign body is there in the esophagus, retrieve it, no this thing, or if the child has any features of obstructive symptoms like inflammation, like noisy breathing, or drooling, or vomiting, or choking, or chest discomfort, it is an emergency. We have to stabilize the airway obstruction prior to doing anything. And if the foreign body has crossed the esophagus, we can wait and monitor. So the one more important thing is, if there is ongoing inflammation and necrosis can progress even after removal. So we have to keep the child under observation after endoscopic removal for esophageal perforation, or tracheoesophageal fistula, erosion of large vessels, pneumothorax, or mediastinitis. One more thing is, more than 12 mm diameter button batteries, it is better to remove it if it is present still in the esophagus. Thank you, sir.
This is a child which we could recollect from ICH days. It's a 2-year-old boy. As I said earlier, the children do not come with the history. It is up to us to identify. The child came with drooling of saliva, Down syndrome child. No fever, just drooling of saliva, no distress initially. Saturation was normal. X-ray showed this foreign body. We see a coin shadow in the neck. This was year 2000. At that point of time, we never had idea anything about the button batteries. We thought it's a coin, and then called the ENT surgeon. The ENT surgeon came to remove, but could not remove that. Then he said it was around 10 p.m. in the night. He said, early morning, we can take the child by around 8 o'clock. At the first case, we can remove. That's what he removed the foreign body, but child deteriorated. You can see that child developed a you can see pneumothorax, pneumomediastinum, subcutaneous emphysema, developed bilateral pneumothorax. We didn't know the reason at all. When we cleaned the coin, only we realized that it is not a coin, it's a button battery. That was the first encounter with button battery at the year 2000, almost 22 years ago. There was one case where we miserably failed. So any coin shadow on the neck, presume as button battery, something like when you see a rope in the middle of the night, think a snake and go away. So always call the surgeon, ENT surgeon, remove it as early as possible. Because even within 4 hours, it can cause perforation. In 4 situations, the button battery has to be removed immediately without any delay. One is in the nose, ear, cricopharynx, and esophagus. These 4 situations, we have to go all out to remove the foreign body as early as possible. Thank you, Dr. Sharda. We'll move on to the next case scenario. Dr. Senthil Kumaran, you managed all the problems which we have not encountered very much in Chennai. Even the paracord spelling, we had difficulty in finding out. So paracord, for all the viewers, it's a toxic, which I gather from the net. It's a toxic chemical widely used as an herbicide, plant in herbicide. A dose of 30 milligram per kg may be fatal. This is equivalent to 78 ml of 24% solution sold commercially can lead to death. Mortality is from 13 to 73%, very worst poison. So we don't have any idea about managing this poison. We owe to Dr. Senthil Kumaran, who have managed many children with paracord poison, I mean children and adults. Over to Dr. Senthil Kumaran.
Thank you, sir. Actually, the paraquat was introduced as a change for the OPC compound. The mainly organochlorine compounds, endosulfan, which was an environmental threat from the Kasaragod matter. They want to change because they stay for a long time and causes a lot of teratogenicity. So they introduced this newer chemical paraquat, which is a herbicide. So when it comes in contact with soil, it loses its potency. So it is not staying for a longer time. But when it doesn't come in contact with the soil, so the potency will be there. So it is mainly used as a sprayer rather than putting in the soil. With our experience, we have seen this is a worst component, sir, and this has to be banned because there is no antidote and the mortality is very, very high. Even the best of best you do, most of the time they die. The mortality depends on the amount of ingestion. If it is more than 40 milligram per kg, or if it is more than one mouthful, then they usually die starting from day 2 to day 5. If it is 20 to 40, then we can play something, we can do treatment, and then we are able to save them. But they are in a long-term immunosuppression, or 2 patients of ours were gone for lung transplant. And if it is less than 20 milligram, they have a moderate GI symptoms. So next slide, sir. Mainly this acts mainly as a redox cycling. I'm not going in detail about this mechanism. We'll go to the clinical features. So this has a 2-phase, initial phase and late phase. Initial phase, you can see pulmonary damage will be there. As initially it starts with the GI and then it goes into the alveolar damage. The important thing in handling this paraquat poison, you should never give oxygen, because as I already told, this poison acts through a redox mechanism. So when we are giving this oxygen, the radical injury will be much more. So the mitochondrial toxicity will be aggravated and they go early. So my professor, where I trained from Sri Lanka in toxicology, were used to say the oxygen is a palliative therapy for paraquat. So in a later proliferative phases, this goes for a fibrosis. Just like how the COVID later it turns into fibrosis, similar things happen here. Next, sir. So the first and foremost is when there is a poison which has been ingested, they have a severe local irritation and starts ulceration and bleeding will be there, mouth ulcers will be there. And one of my colleague from Taiwan who did toxicology with me was found that when the irritation or a burning sensation in the entire body develops, it is a poor prognostic indicator. So even after giving a local anesthetic, but still the patient is complaining of irritation and burning sensation, then this is a poor prognostic marker. Next slide, sir. So initially most of these patients will be asymptomatic, and later they will present to the emergency room with the breathlessness, toxic myocarditis and ARDS, and then they will go for a multi-organ failure and death. And if they are taken more amount, and cumulative toxicity is very, very high. I will share 2 of my cases. This is one of the big shot in the E-Road who is having a marble shop. Lot of insects comes. So he discussed with the insect vendor. They suggested to go for a paraquat, and they told it is very safe and it is not causing any problem. So himself tried to spray, and unfortunately he didn't wash the hand, and regularly he used this and tried to eat some sweets or food like that. And over a period of 3 months, he presented to ER with acute breathlessness and hypoxia. Initially, it looks like a interstitial lung disease, but on evaluation found to have multi-organ failure, and then he succumbed to death. Another one interesting case in adolescent, it's a 14-year-old girl. One person was proposed for a love, and she didn't accept. So then this fellow told that we will be a friend, and started giving daily a fruit to her. So after taking this fruit over a period of 10 days, she had developed some oral ulcer. So locally treated with some pain gel and other thing. it was not settled, and then over a period of time he developed breathlessness and ultimately landed to our emergency room and found to have paraquat poison causing ARDS and multi-organ failure. We lost her. Next, sir. Next slide, please, sir. So the investigation, what we need to do is this. Another one important positive thing is this paraquat is always stored in a plastic container. If they are changing and stored in the glass container and they have taken in a larger amount, nothing will happen. They will survive because paraquat binds to the glass and only the solvent will be there. So when we take the patient comes to the emergency room, you do a multi-organ evaluation like ECG, X-ray, ABG, everything you can see. In the initial phase, it will be looks like a normal, except in ABG, the lactate will be very, very high. And if you do a echo on the second day or third day, the classical toxic myocarditis features will be there. And we can do a serum paraquat level. Usually we send to Amrita to analyze this. And to confirm that, you can do a bedside urine dimethoate test. It is very, very easy. Your lab people with the compound which is available in the lab, we can do. Next slide, sir, please. So it's nothing, you don't need to do a spectrometrography or any other thing. Bedside, you can do, take a 5 ml of urine, add 5 ml of sodium diethionate, and you just see there will be an intense blue-green. So it will be a positive. Once the patient enters to the emergency room, you can do this and start therapy. After 6 hours, if you repeat, you can see the discoloration. It means that the paraquat is reducing. If the color is more intense, that means the more amount of paraquat is excreting and it may cause a renal injury or lung injury. Next, sir. So management, if it is asked in a pre-hospital care, so they don't have activated charcoal or any other thing, immediately tell them to take a clay. Okay, when it comes in contact with the clay, immediately the paraquat will lose its potency. And if they are having multani matti in their house, which has been applied for the face by the females, that can be given immediately, or activated charcoal can be given. So we did a comparative analysis between a clay, activated charcoal, and multani matti, and we found that clay and multani matti is little superior than absorption of activated charcoal. So we advise to go for a multani matti or clay. And you need to do a gentle decontamination because it can cause a esophageal perforation. So start early charcoal hemoperfusion and put the patient on immunosuppression and wait for 10 days. If the patient doesn't deteriorate over a period of 10 days, then the patient will be able to alive. The important things what we have observed is the patient who survived after 10 days will almost go for a total alopecia, and it will take at least 9 months for the hair to regrow. This is one important thing. And the patient has to be put on a steroid for at least for 3 to 5 weeks subsequent of discharge. Next slide, sir. And other supportive treatment has to be given like a local anesthetic spray. And you can, if the patient is complaining of severe acidity and burning sensation, we can try upper GI scopy after 72 to 96 hours. Before that, it will be very fragile and there is more chance of getting for a perforation. And other important thing, if they have taken and then they have vomited, there is more chance of developing airway edema. So airway management has to be done. Next slide, sir.
Thank you, Senthil, for elaborating on a very important poison which are rarer but which are dangerous. So I like to thank all the panelists. If you have just, I also like to thank the viewers for waiting for this much of time. I'll just take only 2-3 minutes to tell about only one poison, because cyanide poison generally they die before coming to the hospital. That's why none of us have seen a cyanide poisoning. But few incidents I just quote. I'll have some 3-4 slides only. I'll complete this. You have met an incident where a Kerala woman has murdered 6 of her family members over a period of some few months by using cyanide. And when I was working in a headquarters hospital, we had a patient brought for postmortem. 3 men went to the liquor shop. 2 persons died within 10 minutes after coming out of liquor shop. Third person was the accused because cyanide was demonstrated, cyanide was given to them. These are the two case reports. Sometimes these cyanide consumed persons may come to the hospital. We should not miss that opportunity. We should try to identify and treat it. That is why I'm just telling this case scenario. This is an adolescent girl, employee of the electroplating industry, was brought at 11 a.m. to the hospital. There is no definite history except that she came to the workplace at 10 a.m. Within 15 minutes, she complained of giddiness and started falling down and developed seizures. So within 15 minutes, she became symptomatic. This is a second case report. It's a published case report. I'm not treated, but published case reports. A previously healthy 4-year-old boy came to ER with nausea, vomiting, sudden onset of unconsciousness, no trauma. Last seen an hour ago before he was eating apricot. Within 20 minutes, started vomiting and became unconscious, low GCS, but saturation is 99%. So when will you suspect? They might come to the hospital. After coming to the hospital, they may die even within half an hour or 1 hour. If you are shrewd enough to identify them, we can save this. That is why this case scenario is presented. So when will you suspect cyanide poisoning? What clinical case scenarios? Any poisoning, death or rapid deterioration within 30 minutes of ingestion is more likely to be cyanide. Sudden collapse of a lab or industrial worker, you should ask about a profession. In jewelry shop, plastic industry, using nitrates as a solvent. In these situations, suspect cyanide poisoning. Fire victim after attempted suicide with unexplained coma or acidemia, you can suspect. This is they called as artificial nail. The picture is shown here. So when somebody is returning back from the birthday party after wearing an artificial nails, you can suspect cyanide poisoning because there is a solution to remove the artificial sculptured nails that also can cause cyanide poisoning. Last one, very surprising one is apple, apricot, tapioca, apple seed, apricot seed, and tapioca. These two seeds, apricot and apple seed, we don't eat the seed. If we bite the seed, this contains amygdalin. Our stomach will convert, this body will convert this plant compound into cyanide after eating, and we can develop cyanide poisoning. That is really dangerous and surprising to know that. Whenever you see a child with toxin injection coming with a normal saturation, think about cyanide poisoning. Only two poisons come with a normal saturation. One is cyanide poisoning, another, all of you know, carbon monoxide. How do you treat? This is the old method of treatment, giving amyl nitrate and sodium nitrate, which will convert this blood into methemoglobin. And sodium thiosulfate converts the methemoglobin into thiocyanate, which is secreted renally. But now the safer treatment is available in the form of hydroxycobalamin. It's a first-line therapy for cyanide toxicity, which is essentially non-toxic and is cleared renally. The hydroxycobalamin converts into cyanide to form cyanocobalamin, which is safely excreted through the kidney. So it's one of the safe antidote. If at all, if you happen to see any child or adult coming with the above mentioned symptoms, please consider cyanide poisoning and keep a cyano kit already available. Some time back, few months back, one of the city hospitals contacted everybody whether we have hydroxycobalamin. None of us have it. So better to stock all the antidotes like methylene blue or cyanokite or desferoxamine. All this to be stocked. When a patient comes, they make the diagnosis, we must be able to save these kids. I'll just pass on the slides. We come to the end of it. I would like to thank the IAP TNSC office bearers for giving us the opportunity. I thank Professor P. Ramachandran for moderating the session. I thank all the faculty who enthusiastically participated and contributed a lot of valuable information. I end with this quote from Swami Swananda. Anything that makes weak physically, intellectually, and spiritually, reject it as a poison. Thank you very much for patient review. Hand over the mic to Rajendran.
Yeah, thank you, sir. It's an excellent presentation. As already myself and Dr. Tangvel sir discussed what's the topic we have to choose. I think we came to a conclusion that it's a poisoning because it's one part is mostly neglected part. And I think Dr. Tangvel sir, I think many of lecturer here that he is one of the expert in the dealing with poisoning, and he's talk also very good in poisoning also. It was an excellent topic he has covered so many years I have seen. So that's why we choose that poisoning this time. And again, and on behalf of IAP TNSC, I thank Dr. Program Convener Dr. Tangvel sir and moderator Dr. PRC sir and resource persons Dr. Sinivasan Subramani and Dr. T.V. Ramakrishnan, Dr. P.V. Pillai, and all the panelists, Dr. Raja Kumar, Dr. M.P. Jayakrishnan, and the basis, and Dr. Sarada Satish, Dr. M. Lakshmi, Dr. Agala Devi, Dr. Sendil Kumaran, and Dr. Punita. And they are really wonderful presentation, and really that case scenario was good because they have own experience also presented. And again, on behalf of IAPTNSC, I thank all the faculties and organizers, and I thank all the delegates. So long they are waiting and they are watching our CME. Thank you, one and all. And sir, any comments, sir? Any comments from anybody? Yeah, thank you, sir.
Thank you very much, sir.
Okay.
Thank you, sir. Thank you. Good night. Good night.
Thank you. Excellent. Nothing but excellence.